Good morning, everybody, ladies and gentlemen, dear friends. So welcome to this year's Brain Metastasis Symposium. It's the 6th, and I have the honor to start this meeting because I'm heading the tumor center, and these symposia were founded as one of the focal points of action for the tumor center at the University Hospital in Zurich. So let's start with the first, the keynote lecture, and Emilie, you are going to make a brief introduction.
Thank you, Andreas. Yes, it's a pleasure to be here this year again. So now it's really my great pleasure to introduce Denis Lacombe, who is the CEO of the EORTC. And EORTC, we all know that's the only academic platform for pan-cancer academic trials. So that's really something very important for us in Europe. So that's all cancers, purely academic, and a lot of very important publication also. And so Denis, you can start to come slowly, yes. So he has really, I don't know, EORTC without Denis, I think we don't think of it. It's simply not possible, I think, in the head of anybody. So, and you have done a lot. So this workshop you have organized when you came recently for this real world data. And so, and also these pragmatic trials. And now you have joined also the board of the EMA recently to continue to develop this trial design and to improve always the quality for us, for the patients, for everybody. So that's a great honor. Thank you, Denis, for being there today.
Okay, so thank you for the introduction, Emilie, and good morning, everyone. It's really my pleasure to be there because also in my early days at the EORTC, I was long associated with the EORTC brain tumor group. Of course, it was mostly primary tumors, but of course, brain mets are very important. So again, thank you for the invitation. I've been asked to share with you a little bit the vision of the EORTC on clinical cancer research at the European level. I need to tell you, of course, that what I'm going to tell you is part of my experience. I've been now in the field of clinical research for 35 years, and the last 30 years at the EORTC. But of course, with the position at the EORTC, with the breadth of the organization, we have a lot of interaction, and we have some, I would say, honorary position in some of the organization. And of course, what I'm going to tell you is also inspired by what I hear at the EMA level. I have 3 roles at the EMA. I'm on the management board, which is more for the functioning of the organization, but I'm also co-chairing the Cancer Medicine Forum. I will give you a word about it, which is more really dedicated to the development and access of cancer medicine. And I'm co-chairing also the EMA ACT-EU, which is accelerating clinical trial in the EU, which is more operational and addressing the non-cancer specific and addressing the operations of, that are downstream to the new regulation. So what I will try to do in this half hour is, of course, to give you, it's a relatively high level, try to give you, of course, a European dimension, the regulatory context in the term of access to treatment and therapeutic strategy, because EORTC, as Emilie said, we are not for profit, we are not a company, we are not developing drugs. So the regulatory side for us is really for access to therapeutic strategy, of course, in an independent manner. So what is the role of such organization in the landscape? And of course, from the clinical research angle, how do we approach all this therapeutic strategy, how we redefine the new risk-benefit ratio? And I will give a focus at the end on one of our priorities, because these are typically academic investigator-driven study, is what we try to stimulate on more, I would say, treatment optimization, de-escalation trial, and pragmatic clinical trial. So just a word about the EORTC for those of you who are not familiar with the organization. As Emilie said, I believe still today we are the largest international multi-tumor, multidisciplinary cancer clinical research organization. It's about now it's 63 years of existence, and basically it's a network of about 4,000 investigators. And just to give you some numbers, we have a cruising altitude of about 3,000 new cancer patients on a yearly basis, in about 25 clinical trials open to patient entry at any time. But of course, there are trials in preparation, a trial in long-term follow-up. So at any point in time, we work on about 120 clinical trials across tumor type, mostly solid tumors. We are not present in pediatrics, and relatively small in hematology. So just to give you a little bit, and you will have access to the slide. This is a snapshot on some of the metrics. An important metrics for the organization, of course, is the publication, peer review publication by the network, but also by the center, by the coordinating center, the headquarters in Brussels, where there is a lot of methodological research happening. And today at the EORTC headquarters in Brussels, we are 240 people, so all professions basically to organize, run clinical research. So that's just a short introduction about the EORTC. I think something for which the EORTC has been really striving and trying always to, and we are still in the field, sometimes a little bit, I must say, challenge, is always aiming to the highest level of evidence. And for us, the golden standard is and remains the randomized clinical trials. Of course, we come from time, and again, in my early days, we had basically only one model. It was the randomized clinical trial. Today, and we see that we have also other type of clinical research, cohort, registries, trial within cohort. We speak about real-world data and so on. But what we realize is that generally in the community, and for the most senior of you, you will remember this large phase 3 practice changing in radiation oncology, in adjuvant treatment, which were really the property, if I can say so, of the academic network, are no longer there. And we see also in the professions, in the community in general, a marked fallback on the understanding of the methodology of clinical trials and what people can conclude or not conclude based on this so different methodology. So that's the first thing that I want to share with you. And we are putting a lot of effort in education, also on methodology. We are not saying randomized clinical trial, of course, is the golden standard. There are other methods, there are other possibilities, but you have to know what you can conclude and what you cannot conclude from this trial. But we always challenge our investigator: what is your benchmarking? What is we are in 25. In the vast majority of the clinical situation, there is something existing, even if it's best supportive care. Try to have a form of benchmarking so that you can conclude. So that's first thing, something that is changing in our community. And also, what we have seen again what is changing is the role of the commercial sector. Again, in my early days, we were really dominant or kind of equal with the pharmaceutical sector. For instance, we had a phase 1-2 unit. We were doing these trials at the time where industry was not so educated, but industry has changed a lot. And how there is clearly a big part of the clinical research agenda that is taken by the commercial sector for good. To some extent, innovation can only come from the pharmaceutical industry. So don't get me wrong. But we also know that they have an agenda which is clear, which is open. It's business, and it does not necessarily take all the questions that we have. So also something that for us is strategic in positioning such an organization is what is our role in the society of today in delivering evidence for who and for which stakeholder. And we are trying indeed with, for instance, the policy work that we are doing at the European level is to position independent research. So not necessarily only the EORTC, but what is the role of independent research in informing patients, in informing doctors, but also in informing society. cost of drugs are very expensive. Usually the pharma sector is not going to study the duration, the optimal schedule. We know that patients are overtreated. So is there, for instance, a role to optimize? So this is the type of things also where strategically we try to position and see how our models do evolve. So there is clearly an imbalance for many reasons between the commercial and the commercial research, and that's what we are trying. We need both, but it's getting more and more challenging. But we have opportunities. I want to make a very, I would say, enthusiastic, a very, I would say, positive looking forward type of approach. Is that there is a lot of innovation, and again, industry contribute greatly to that. But we need to understand how to use this innovation. So we have new surgical techniques, new radiation oncology technique, breadth of different class of agent, and it does not belong to any single manufacturer beyond this technology to understand how to use, how to combine, how to sequence. And I think that's the role we have to take. Of course, around that, the landscape has dramatically changed. Well, again, dramatically in the sense also that we have new possibilities, and data science is there. We have new approaches to look at the data. The data are of course, there are different type of data, not only clinical, imaging, translational research. Also, because we work usually later in the drug in the process, because the drugs have to be approved first to be on the market. So, but we see that the maturity of the drugs which we have to work is not the same as some years ago. Why? Because again, these large clinical trials are no longer there, even in the commercial sector. We see drug register based on very small trials, so the information is not really there, and it creates a lot of issues also for access, even in our so-called rich countries. So there are a lot of issues here that we try also to address and to position. So just sharing some selected observation. In Europe, the frameworks are relatively complex. We have been, in a few years, we have a number of new regulations, GDPR, clinical trial regulation, medical device regulation, in vitro diagnostic regulation. Now we have the HTA regulation. It has an impact because we have to implement that. So the cost of clinical research is increasing. Again, we have a lot of different types of clinical trial, and we have all of those at the EORTC. Again, if the golden standard remains the randomized clinical trial. Again, I've already mentioned the smaller data sets, but also the fact that the HTA body, so the health technology assessors, those who give basically the green light for drugs to the payer to be reimbursed, are playing a greater role. And I believe they are people we have not spoken historically, but we are trying to speak to them because they can be partners, especially for access to funding, if we can find a good way, what's in it for them as well. On the other hand, the public funding in general is much more challenging for all the economical situation. And again, the commercial sector has taken a different position, and negotiating with industry is no longer that easy. We really have to know who we go for and with what. Otherwise, the door closes, and it's very challenging. So we really have to know what is the added value that we bring to the commercial sector. And also something that is, again, in our shop, is that we are very fragmented as an academic community between international, national groups, different discipline. It's not evident, but I think we would gain in getting, of course, a little bit more cohesion to have a critical mass and actually position, again, independent research in the landscape. So a number of challenges, but how do we transform that in opportunities? So again, I've already alluded that This slide actually is part of the Cancer Medicine Forum of the EMA, which again, I said I co-chair. We had a workshop last year, and the role of the Cancer Medicine Forum is really to address what are the key critical questions that are not addressed at the time when the drug is registered. So basically, this gap between the data sets available for the regulator and the data sets which are needed for treating patients in real life. Again, because there are challenges for society, overutilization, cost increase, not necessarily association between the magnitude of the benefit that is measured often on surrogate endpoint and the real benefit for patient and the price of the drug. And as a consequence, these trials are not necessarily so informative as our historically large phase 3 that we used to do. And again, the economic model is not sustainable. So how can we contribute again, if you remember this triangle, in this in rebuilding an ecosystem where this question can be addressed, and who best can address that the independent sector, because you see that even if we collaborate with industry, there is an agenda here that industry will never address, because of course it's not necessarily in their primary interest. But we discuss with industry because we need to find a good balance. So basically, we've been saying that. Actually the work starts when the technology reaches the market, and there are a number of questions that we have: sequence, dosage, de-escalation. We have at this time on our agenda at EORTC 6 big de-escalation question trials that we want to do that are on the starting block. Which we discuss with the regulator. So it can be about duration, benchmarking, specific patient population like older adults. And again, how can this be informative for the healthcare system based on clinically relevant endpoints, survival, quality of life? And here we are also exploring how we can get funding, because if you can save a lot of money, and we have some health economics models that show that if you have a de-escalation trial on an expensive drug, you can save a lot of money in the healthcare system. So how can there be a return to support this type of trial, purely academic again? So these are things that are changing, where we try to understand how at the European level, an organization like EORTC can be a partner to stakeholder. And something that is important also to highlight, I see a few radiation oncologists in the room, is that unfortunately, all what we are talking at the European level is very much drug-driven, and the clinical trial regulation. All this is for drugs. Other disciplines are largely ignored. Why? Because the pharma sector is not present, and this is also something we try to voice. Again, therapeutic strategy, local regional treatment, and systemic treatment. But this is also quite a challenge. So basically, we don't get me wrong, we work with industry, the regulatory trials are important, but again, as I've tried to say, it's a bit a slide to pause and to make a sort of summary of what I said. These trials are not necessarily informative. The primary endpoint is not necessarily clinically completely relevant. Patient population for these trials are heavily selected, so with a very poor external validity, but we need these trials. The regulator needs this trial. So how can we have basically a continuum, and sometimes even going back to earlier trial, with trials that are more open, with large eligibility criteria, reflecting really the population to address a bit of these challenges: duration, cutoff values of biomarkers, which is the ultimate population which benefit, rare cancer, elderly patients, and so on. So I think that's what we are trying to see. How can we have this better balance in Europe in that respect. And that's why the policy work is very important. Again, I was trained as a scientist, as a medical doctor. I had to learn a little bit the policy work on the job, if I can say so. But we have to be present, because that's where the decisions are made, at the policy level, at the regulatory level. And you see all these actions that we have taken, again, at the level of the EMA, at the level of the implementation of clinical research. Just to give you, because I could speak for long, but at this point in time, if you do an optimization trial where you change a little bit the way you use cisplatin or 5-FU, which are far than being new drugs, okay, it's still defined as an investigational situation, and the regulation you apply for an optimization trial, understanding, again, a therapeutic strategy like this, falls under exactly the same rules than a completely new drug. It does not make sense. And we still have these trials. We communicated at ESMO last year, a trial we joined, the Australian group which we joined, communicated a top-tier trial addressing basically decommissioning radiotherapy, chemotherapy in pre-op of upper GI cancer. So these trials are very important, and they are done with very old type of treatment. Again, rare cancer, we have a discussion at the European level to try to change the paradigm of adult cancer. We have a workshop in preparation with the regulator on older adults. We have a big program, CISA call, in partnership with the FDA. We work also with the FDA and EMA on how to optimize quality of life and quality of life methodology in regulatory decision making. We are in contact with a number of other organizations, including the WHO, which stimulates these also pragmatic clinical trials. So I think there is a role for the academic community to really partner to increase our lobbying power, because it's very difficult to be heard, because economically we are very weak as compared to the commercial sector. So in the balance, we don't wait a lot. I think something that is important also is to join other parts of the world. We have intercontinental trial, and for us also they are a good way to demonstrate that things are sometimes easier outside Europe. So when you speak to regulators and you have hands-on expertise on this global trial, it adds, of course, in the credibility, and something that Emilie has alluded to also, and that we encourage our groups to do so. Since a few years, we've been doing workshops at the EORTC. For instance, we had one focused on real-world data with a publication. We just did also a workshop on the role of pragmatic clinical trial with the FDA and EMA, and we have a Lancet Oncology that is about to be released any day. So these are very important papers on which we can build and of course communicate. But I think it's also disease specific. For instance, we have really stimulated our groups to do a workshop around specific tumor types. We did one also around, for instance, GU oncology, on kidney and bladder. And basically you bring people, you think about the future, and then at the end of the day, you have key questions on which you try to develop. And we have sometimes pragmatic questions. So basically we try to link, of course, the expertise that we have at the EORTC headquarters and the expertise of our group, again, to position this type of trial. A word on the partnership of the commercial sector. I will be very short, but again, it has changed. When they sit at the table, they say, okay, what do you bring? What is your added value? What are your costs? What is your benchmark, fair market value? That's the type of questions we have. As an academic group, if you are not a bit business oriented, basically you don't survive this type of discussion. So we really have to see also what type of trials we do with them. And to be sharp, they have no time. They no longer have time. We also know that the big pharma doesn't do really early drug development, or less and less. They go through biotech, they acquire biotechs. Biotechs are, well, basically it's a matter of survival. It has to be fast. So basically it's no longer the old type of pharma model, and we have to adapt to that. That's for sure. So sometimes the gap between what we can do together is bigger. But again, I think there is room, and all our groups have a form of collaboration with industry when really the agenda meets. For instance, our brain tumor group is having this trial, which is a radioligand in meningioma. So radioligand is something important for the industry. It's quite hot. Meningioma, where do you want to do that outside a group, an educated group? So here it matches, but it goes. So we really have to know where are the added forces. So that's one of an example. If you go for a lung breast cancer, I would say not really sexy drug, or so it's becoming more difficult. I know that I still have basically 10 minutes. I just would like a little bit to give an emphasis on pragmatic clinical trial. Why? Because I think they are an important card to play for us. Again, we did this workshop a year and a half ago. The Lancet Oncology is about a paper with the regulators. So this is the type of workshop where we bring everyone, the regulator, FDA, EMA, the payers, the HTA bodies, the patients, the academic group, the industry, and we try to have some sort of consensus on what is the value of these trials. I think that what we have noticed is that even for we made a lot of research. If you look at the clinical trial published in the last 15 years or so, which have pragmatic in the title, and you look at the design of this trial, and they are everything but pragmatic. So I think we have to learn also in the academic world what is a pragmatic clinical trial, so that we can have I would say a consistent dialogue with the decision maker. So basically, we are looking at trial that does not exclude people, does not exclude patients, minimal eligibility criteria, inclusive of routine practice, not necessarily in large cancer center, but sometimes in community center where the patients are, again, for very important, what I call public health questions that are going to measure only very important things. We always build on the example of the recovery trial, and for at the time of COVID, it was one-page case report form, really the essential, and it made a difference. And of course, this trial will not tell you why they are not translational supported and so on. It's not there to give an explanation. It's really to tell you what if something happens and why, and basically and the rationale why. So basically, usually the large community, and that's what we see in the younger generation of investigators, that's why we have also an education program, is that they've been growing also within this industry regulatory type of, to some extent, brainwash. And most of the clinical trial, when you speak about a randomized clinical trial, at least at the policy level, they think that a randomized clinical trial is a regulatory trial, so with strict eligibility criteria that has many additional procedures outside of routine practice at selected institutions, again, with large data collection, and again, endpoints that are not necessarily informative for treating patients. And what we are claiming, again, these are needed, but we want to do this trial which are wide inclusion criteria that really don't change anything as standard practice, conducted where the patients are with limited data collection, and of course important endpoint based on which we make a difference, so they have good validity. So we are using this tool, which has been published by a group in Edinburgh, where basically you look at a certain parameter, again according to the number of eligibility, where you are going to activate your clinical trial, how far you ask or don't ask additional procedure, how far you follow up the patients according to routine. So basically, it's some sort of a web, and depending on the figure you get on the criteria, it tells you I would say in a visual way how far your trial is pragmatic. And we are trying more and more to use that at the EORTC, actually to make the trial simpler and simpler and simpler. So basically to unlearn what we have been doing and go back a little bit to the basics. Of course, they have challenges. I'm not saying these trials are easy. because they can be simple, randomized clinical trial a priori, but they have challenges with always the dispute around near equivalence, non-inferiority. They are not funded by industry. They are out of the radar of regulatory guidance, and often we are asked to apply the same standard as for any new drug, which is an issue. So no legal framework. Investigators are not necessarily experienced. And of course, the big thing is that recruitment is sometimes very difficult because a similar patient population can be, of course, taken by a commercial trial, which pay more, certainly. Maybe a new drug is more sexy, more appealing for investigator. And often they also raise ethical concern, because when you go to de-escalation, it's not easy to say to a patient, okay, we are going to de-escalate your treatment. So we think they are very important, but they have challenges. And that's why we have done this workshop to really have try to get an understanding of what are their limits, what are their possibilities, and again, that all stakeholders would understand how they can use them. So this is my last slide. Yeah, maybe before I come to the conclusion, I would like to tell you that I told you we have 5 or 6 of these trials, and now we are in active discussion with the payers. The problem is that, of course, in Europe, the payer, of course, is national, so there is no supranational mechanism. You have to discuss with each country, but this is something we have a little bit taken our pilgrim stick to go country by country to see if they would look at funding this type of trial, because they would have a benefit for society. So again, possibly we have the most complex regulatory system, but again, we have to adapt, but we have to also to support them, master them, and also guide the policymaker to changes where needed. I think we have to improve the professionalism of the independent sector, because again, academia is very variable. There are a number of different academic groups with different variability in quality. And if you want to sit at the table of the EMA, the policymaker, you have to demonstrate that you can provide this quality if you don't want to have the credibility, but it has a cost. So the cost of clinical trial is increasing to apply this professionalism and implement all this regulation. But again, I think we have to strive for this positioning in this process of access. It can be a route for recognition. Again, EORTC, 60 years of existence, practice-changing trial, but nobody has asked us to exist, basically, but now it's more difficult to exist. So how can we have some sort of, can we be given a card, again, to contribute to the ecosystem, with the new stakeholders, which are very active, again, society, HTA, payer, healthcare system, still continue, and that I need to call a little bit to the surgeons and to the radiation oncology, is to help us also to voice multidisciplinarity strategies, because that is getting very limited visibilities. Of course, despite the challenges with the commercial sector, there are new opportunities, because we have knowledge in academia, and we can help them. Again, it needs a little bit of intelligence work ahead to understand where to position. And the last thing, which is very important to me, because is the principle of independence. At EORTC, we are very strong on that. Means that when we collaborate with the industry, we are in the driving seat, database, trial design, database, mandatory publication. Of course, all companies don't necessarily accept this level of control, and we know that there are academic groups which are more permissive, but this is not in terms of how they collaborate with industry. For us, the independence is very critical for our investigator. When they sit at the podium at ASCO, at ESMO, at least we can stand right. It's really independent. It's been completely independently analyzed, whether positive or negative. And also it's very important, again, to do the policy work. And I can tell you, I'm constantly questioned by the EMA on how we partner with industry. And if at some point in time they find something where there could be a conflict of interest, you are out. They cannot tolerate that for public, because they are also under public scrutiny. So the criteria of independence are extremely important to be at the table at this type of discussion. But I can tell you, it's very difficult to resist. We get a lot of pressure to relax and to go for easier money and collaboration with industry. But this is something we strive not to lose. Otherwise, I think the spirit is gone. I think I'm just writing my time, and this is my last slide. I hope I could share some of my passion, some of the principle I'm standing for, and I hope it raised your interest. Thank you.
Thank you very much for the next lecture, and also for all the work that you are doing every day. I think that's great for us. I don't know if there is any question. Yes, Andreas.
Thank you very much. This was a very interesting and stimulating presentation. I would have two questions. The first one is alluded a bit to real-world data. So what's the space of EORTC and other larger associations in making access to patient data possible? That's the first question. And the second one is, you mentioned the approval system for drugs. And somehow the approval system is very rigid, because you approve and then very rarely the label is changed. So very often labels are outdated after a few years. So do we need to have a change in regulation?
Yeah. So for the first question, we did, and I encourage you, or I can share the publication. We did a workshop on real world data. I think the problem is that real world data is a big bag. Okay, it depends if you look at real world data for diagnostics, for treatment, or for instance for long-term follow-up. EORTC is a treatment organization. We don't think you can conclude on real world data. That's for treatment decision. I think we believe it's a tool, and we have our platform getting to real world, based on which we raise hypotheses, we understand the field, and so on, and then we can do clinical trial based on the information that we can get. This is, for instance, the model that is being used for radiation oncology at this time. I think that's a word of caution we always give, because we hear sometimes opposing real-world data and randomized clinical trial, but to me it does not make sense. For instance, pragmatic clinical trial is a way to access to real-world data in a robust manner. You are doing a trial in real world, but you bring robust methodology into the real world. So I think there are a lot of I would say confusion in our perception, and also that's where I said at the beginning, we see a little bit fallback in the understanding of methodology and what you can conclude from methodology. So we are open, we are looking into federated model, we are looking into artificial intelligence, but so far, and even the regulator is only using real world for the long-term monitoring, not for decision at this point in time. So of course, it's a field that is going to evolve, but at this point in time, we consider it as a tool, not as an end, as a mean, not as an end at this point in time. And for the second question on the label, yes, that's a problem of the of the commercial sector, and that's why we are doing also this policy work. Once the label is there, when they are on the market, they are disincentivized to do any type of research, and this is one of the limiting factors. There is the pharma regulation, which I have not mentioned, but because it's not yet there, it's in discussion. But the pharma regulation, Article 48 of the pharma regulation, but if it goes through, will give I would say, some role to independent sector to go to the regulator and change the label. But it's not yet. It's not yet there at this point in time. Even when EORTC, we have practice changing clinical trial, and we have that on a regular basis. I would say in IITs, then we have to negotiate back with the manufacturer, because only the manufacturer can go to the FDA and the EMA. We can't go because we are not for profit. It's only for manufacturer. So this is something that is in discussion. It raises a lot of questions, because if you are an independent sponsor, you change the label, what are the responsibilities behind, the liabilities, and so on. So there are a number of legal questions behind. I think it's another discussion for 10 years, I think. But okay.
Yes.
Thank you very much for all you do and for your talk. I think that the conundrum that all the cooperative groups are in right now, both the EORTC, I'm a member both of the EORTC and the Breast International Group, is only going to be solved if the regulators, and that's why it's so important you're in the EMA, decide to support academic research and research that asks questions that are important for society, for cost cutting, for access to all the patients. So there's no way around it. I mean, I just came back from a meeting about a trial of de-escalation that is funded by a Horizon project. And I think this is the only way to really do large randomized trials that ask the questions that pharma doesn't want to ask.
Yeah. I can only agree with you. We also have free de-escalation optimization trial supported by the Cancer Mission, and that's why that's exactly the objective of we stimulated EMA to consider this Cancer Medicine Forum to help us. The problem is that the remit of the regulator is to some extent very limited, because anything post-marketing is a national competence, is no longer a European competence, so they cannot do much. So what they do is on the top.
But the processes are so bureaucratic and complicated compared to the other side of the Atlantic that they make things more expensive only because the processes are so bureaucratic.
Yeah. No, agreed. Yeah, and this is part also of our. I would say, Europe is not one country, and that's a challenge. The European institution, at the end of the day, in our field in health, they have limited power. It's not in the Treaty of Maastricht, so it remains a national competence, and you have to put 27 member states around the table for agreement, and that's a challenge for us, because our agenda is mostly post-marketing. So our partners are these HTA payers, but they are 27. It's not one EMA; it's 27. So that's the difficulty.
I know we're running out of time. Maybe a quick vision from you. We have not been successful everywhere, right, at EORTC. EORTC is still not European. We're missing out of Southeast Europe, of East, of Scandinavia. We discussed that. Why is that? And do you think in 5 or 10 years we are really European? Is that possible?
Yeah, that's a historical challenge, and we've been deploying a lot. I think it's often multifactorial and different from region to region. For instance, something that we have identified with Eastern Europe, where the economic situation is more challenging than for us, is that with an EORTC trial, you don't make money, you lose money. basically with an IIT. So for them, it's a limiting factor. Historically, the Nordic group has been extremely well organized. They have their collaboration, so it's a little bit difficult to penetrate. South of Europe has been a little bit more challenging, but we are doing better work now. For instance, we have a master agreement with Portugal. So any clinical trial in Portugal goes through the government, and it is deployed in Portugal. So here it's a nice model. Spain is getting a little bit also more active. There are countries like Greece, indeed, for instance, where EORTC has more difficulty because the volumes are not necessarily there, and because of the economic constraint for us, also opening a country is extremely costly. So we would rather open a country where you have 5 centers and I would say 50 patients than a country where there is 1 or 2 centers and 10 patients, because economically for us also it's not sustainable. So that's also sometimes it's multifactorial. These are only some of the limits. So there are others also.
I have also a question. Can you share your view on the collaboration also with countries like UK and Switzerland? Is it
with
UK or Switzerland outside of?
Oh yes, for us that's absolutely UK. The Brexit did not really affect anything because we, of course, here I focus mostly on the European, on the EU countries, but we work in Switzerland, we work in UK. That's absolutely no major issue, and I must say. The only challenges sometimes has been, especially in the UK, to access to funding there. But we have a liaison office which is helping. So so for us there is basically that's not a limit, because non-European but non-EU in non-EU countries are not necessarily a problem.
Good, perfect answer. So thank you very much. If there are no more questions, I think we can move to the next session. Andreas.
Okay, thank you very much. So let's start with the first session. We now move into a bit of quite fascinating science. So 20 years ago, we mostly concluded drug testing on tumor samples is not useful with the methods we had at the time. And we've seen some revival of drug testing. And one of the persons who was instrumental in doing this is Berend Snijder. Our next speaker, he's professor at ETH, the Swiss Federal Institute of Technology here in Zurich. And he's developed a method which is a little bit more complex, but very interesting how tumor samples can be tested. You also heard something about methodology, and that's why I'm particularly happy and proud to say you are leading such a trial together with oncology and hematology at USZ with Markus Manz. And we are very interested and curious to see what you can tell us about how to test drug testing in oncology in a real clinical trial.
Thank you, Andreas, for this wonderful introduction. It's a pleasure to be here today, and I have to apologize. I'm losing my voice a little bit. My daughter has been sick for a long time now. It's how it goes. So my name is Berend Snijder, and I apologize to those of you that have seen the introductory slides on pharmacoscopy already many times, but because there's still some new faces in the audience today, I thought I'd repeat it nonetheless. But it's a pleasure to give a bit of an update on our work on adapting this ex vivo drug testing platform for patients with brain metastasis. Do we have a pointer, actually? The mouse? Okay, yeah. So, one of the central questions we try to work on in the lab is how can we identify effective personalized therapies, amongst others, for patients who have no actionable genetic or molecular markers, targets, which usually is the majority of patients, unfortunately. For patients who have relapsed or refractory to their targeted therapy options. Or for patients who have no systemic treatment options at all. Think of patients suffering from rare solid tumors for which there have been no clinical trials possible. But inversely, also for treatments for which there are no molecular biomarkers known, think of chemotherapy and other such older technologies. For complex drug combination treatments, how do you optimize those on a single patient basis? And not just considering drug sensitivity, but also toxicity of the treatment, right? The patient needs to be seen as in a holistic sense. We don't just try to kill cancer, but we also try to keep the patient alive. And in that context, my lab works in the field of functional precision medicine, and I appreciate Andreas' words, because it's very clear that this, in fact, the field is very old. It goes back to the 50s, where people were systematically trying to put drugs on patient cells and seeing if the drugs would kill those cells or if the cells would survive the treatment in a lab setting. It's old, and it's also hasn't been successful for a long time. So it's by no means embedded in clinical routine. And in part, we think it's because the technologies that were used at the time were rudimentary and not yet having the properties needed. But the process, that in principle, can be very simple. Patient cells come from the clinic, clinical collaborators go to the lab and get exposed in our setting in these kind of high throughput drug screening plates. So we can actually test hundreds of different treatments and treatment options directly on patient cells. What we then do, somewhat uniquely, at least especially when we started this work now more than 12 years ago, is we use image-based readouts to measure with single-cell resolution in an immunofluorescent setting which cells respond from the patients, which cells respond to the treatment, and which cells do not. So we do this more often than not with multiplexed immunofluorescence after the drug incubation, then come in with automated microscopy to take pictures of all of the cells, perform single-cell image analysis, often involving deep learning algorithms to classify each individual cell, and turn these very large data sets into simple reports that say which of the drugs in our wells most specifically kill the patient cells. And that's a very simple readout, but that has this built-in toxicity checks because we try to specifically keep the healthy patient cells alive while looking for drugs that kill the cancer cells in the sample. I won't talk about it, but on the side, the lab also has a strong interest in systems immunology, and basically the exact same platform can be used to also study the interplay between the immune system and the cancer cells, and even immune systems on its own. So another way, and I apologize for taking the sample of a blood sample in a brain metastasis setting, but another way of looking at this is that within a few days from a small blood draw, bone marrow biopsy, or in fact any solid tissue biopsy, we can perform and generate such high throughput drug maps, where each small square you see here is a chamber in which we test the response to individual drugs. The pointer's a bit laggy, I won't use it. And that is a very highly zoomed out view. The actual original resolution of our data is true single cell resolution with this kind of immunofluorescence readouts. And you see immediately that you get more than just marker expression. You get cell morphology, you get cell-cell interactions that we systematically analyze using computer vision, classifying each individual cell into its cell type, its cell state, and its, for instance, morphological and spatial patterns. And I've mentioned that we've been working on this technology now for over a decade, and in fact, this technique has now been used for almost more than 10 years in trying to identify effective treatments for patients who have run out of treatment options. And one of our early examples, now from 2015, so truly almost 10 years ago, was this frail lymphoma patient that, and this work started at the Medical University of Vienna, the Center for Molecular Medicine, where I did my postdoc. This frail lymphoma patient that had relapsed to standard of care chemo and immunotherapy. We received a small lymph node biopsy, tested 100 possible treatment options, prioritized them for those that specifically killed the cancer cells, and we gave that report back to the treating clinicians, and they were excited about the second best hit that we identified, the BTK inhibitor ibrutinib, and this patient had a long-lasting complete response to just this monotherapy, despite having relapsed to chemo and immunotherapies. We've run two separate sort of feasibility trials in the blood cancer setting. The EXALT-1 trial for lymphomas, mostly lymphomas. It was actually a mixed patient cohort. 52 late-stage patients receiving such pharmacoscopy-guided therapy. We then tracked these patients for multiple years and saw that a fraction of these really had exceptional clinical responses only to pharmacoscopy-guided treatments. And here in Switzerland, together with Thomas Papst at Inselspital Bern, we've done a small feasibility trial called the DART-1 trial in late-stage AML patients, where we saw that patients receiving highly recommended treatments had an overall survival, median overall survival, that was 3 times those of patients receiving dose scoring or non-guided treatment. And as Andreas alluded to, and this really is sort of it's a one-slider, but it's been a few years of work. It's that we now have approval and are running together with Alex Theodoridis and Marcus Mans here at the hospital, the RAPID-1 trial. And why am I very proud of this? It's basically, as far as I'm aware, the first randomized controlled in vitro diagnostic performance study for such a functional precision medicine platform. So it means, in this case, for relapse refractory AML patients, they get tested. If the test is successful, historically more than 90% of the case, the patients get randomized to either receive standard of care or pharmacoscopy-guided treatment within the limits that are allowed to us in the context of an IVD performance study. So there are, in fact, quite a few constraints imposed upon us by Swissmedic, amongst others. And then eventually we'll compare. So this is very much ongoing. We'll compare response rates and amongst others, patients, the fraction of patients that could be bridged to bone marrow transplants. I could go on for days about the regulatory hurdles in setting this up. It truly has taken multiple years in getting the paperwork together, consultants, a lot of money actually to get this going, but I'm very proud to say that this study is now running and recruiting. So that begs the question, okay, this technology clearly seems promising for blood cancers. What about solid tumors? And here I have to acknowledge Emilie and Michael for a long-standing fantastic collaboration amongst many others, also in the room. Because together with Emilie and Michael, what we've done is really try to adapt pharmacoscopy for central nervous system tumors, including glioblastoma, but also patients with brain metastasis of any kind. And the assay is as simple as it is for blood cancers. Except that we do a mild dissociation of the patient tissue following surgery, then put these cells on these drugs as soon as possible following the surgery. And then after 2 days of drug incubation, we fix and stain the cells, image them, and analyze them in much the same way as we analyze the blood cancer drug screens. So we maintain cellular tumor complexity. Whatever we get from the surgery is basically what goes into the assay wells. So again, healthy cells provide internal toxicity control that is patient-based. We try to minimize sample processing time to really keep this process fast, such that again, within a few days, we can come with detailed reports on the drug sensitivity of that one patient to tens, if not hundreds of drugs. So, just to show some of the images of what this can look like, and this is recently published in what for us really is a milestone paper in Nature Medicine just last year, worked by Soyan Lee, who was a postdoc in the lab at the time, shared with Tobias Weiss here at the hospital, of course in collaboration with Michael's group. So with adapting this approach to solid tumors, you really start to appreciate the complexity of solid tumor tissues. The cellular heterogeneity increases, the cell morphologies increases, and I think it's beautifully visualized in this glioblastoma surgery material that you see here, where the yellow and green cancer cells start to make these elaborate cell networks, even in very short term, just 2-day tissue cultures. So just recapitulating a few highlights of this study across 2 different cohorts, we could see that, and we could show that what we measure in vitro using pharmacoscopy on these glioblastoma patient cohorts is, with regards to response to temozolomide, clinically predictive of those patients that have benefit of temozolomide versus those patients that are more resistant to it. And we could then use this high throughput drug screening platform to identify new treatment options. And in this case, we look for drug repurposing of neuroactive drugs, identifying a clinically attractive antidepressant called vortioxetine, for which we've been trying and are fighting to get the funding together to actually run the clinical trial to test this efficacy in the clinical setting. There's a lot of details in the paper. I'll refer to the paper, of course. What we're here for is work on brain mets. And again, just like glioblastoma, the process is the same, the culture conditions are the same, and that's sort of something we can get away with because the culture conditions are so short. But of course, we need to adapt staining panels. So for instance, here you see a brain metastasis of a non-small cell lung cancer patient, where we stained the cancer to identify the cancer cells with TTF1 transcription factor and EpCAM, epithelial cell adhesion marker. and counterstained for CD45, so healthy immune cells. So that process is very much feasible, and in fact, what we see across so that means we can turn these high throughput image-based maps again within a few days into a prioritization of possible treatment options for this one patient. We've been really, together with Emilie and Michael again, we've been running a small feasibility cohort on patients with non-small cell lung cancer, brain metastasis specifically. We find excellent technical feasibility. So for more than 90% or for 90% of the cases, we find that the approach managed to return significant on-target drug sensitivities for each individual patient. Of course, we don't know if those are active and effective in those patients. That remains to be shown. And then why I want to show this cohort is, so each column here is a different drug. I lost the mouse. Each column is a different drug in this heat map, and each row is a different patient. And of course, with clinical annotations and additional molecular annotations, we can then start to explore if the patterns that we see in these drug response matrices are suggestive of novel hypotheses, for instance, and treat them as highly exploratory associations. What we could show in this cohort, well, one, on technical performance, we see that across technical replicate measurements, we have really good reproducibility. So things that we call a hit is a hit not just for one well random beam, but when we repeat the measurement in the same patient sample, those hits are reproducible. And then also, I'm struggling a bit with the computer. And then we can start to explore and treat this as purely exploratory, but we can start to explore molecular associations with drug sensitivity and features of the patient or of the tumor. And this cohort, even if it's tiny and highly exploratory, still came up with a number of fascinating associations that I just wanted to show as a proof of concept for how doing this systematically across patients can generate new hypotheses. One of the striking things we see is that the few patients that have confirmed EGFR mutations in the brain mets themselves are highly responsive to many drugs. That doesn't per se mean that those patients will do well in the clinic. Probably what it means is that those tumor tissues are more active, more proliferative, and therefore easier to kill in an in vitro setting. That doesn't mean that the test is not useful, because within the different treatment options, you can still prioritize and focus on the most active for each individual patient. But for a number of related but also irrelevant drugs, we see good killing, specifically in those EGFR mutant patient samples. Something else, we see that those patients that were receiving systemic treatment until the brain met surgery show ex vivo resistance to erlotinib, which is of course a tyrosine kinase inhibitor actually approved for non-small cell lung cancer, suggesting that there might be, and these patients probably did not get erlotinib. We don't have the data right now, but suggesting there might be sort of a generic tyrosine kinase inhibitor resistance, possibly in these patient samples. And something else fascinating that we see is that there's a number of drugs where the ex vivo drug response starts to stratify the progression-free survival of this heterogeneous cohort. So again, that should not be taken for being clinically predictive. This isn't matched to the drug that the patient actually received. And in fact, many of these patients did not receive targeted therapies. But it might suggest that there is indeed aspects of tumor physiology that are captured in this assay. And, wrapping that up, and again, another story of something that has been multiple years in the making, and this one is not yet approved, but we're very much working on it. Emilie has been pushing wonderfully this design of the trial that we call Evidence.BM, so pharmacoscopy-guided treatment for patients with brain metastases of any kind. And just a few highlights of the trial design. We're currently in revision. The trial is to go also get Swiss medical approval, so the paperwork required for this trial is again highly significant. But we aim to include 102 patients with solid tumor brain metastasis of any kind. Pharmacoscopy test sensitivity to 66 drugs that include only drugs that are blood-brain barrier penetrant, at least to some extent. And in this design book, and this is not to my credit, this is very much Michael and Emilie, will employ a 3-to-1 randomization, where the majority of patients enrolled in the study will receive pharmacoscopy-guided treatments post-surgery. So that's also my acknowledgement in the brain met section. Michael and Emilie have been instrumental and very much pushing this. And of course, there's the team on our side at ETH, sometimes in Greece, but mostly at ETH, doing actual wet lab work and analysis work, including Soyeon Lee, hiding here. Alicia, were you there, Alicia? Not sure. And several others from the lab. So with that, I'd like to wrap up, take your questions, and I'm very happy to have been here today, to be here today. Thank you.
Okay, thank you very much. Very interesting presentation as always. Do we have questions to Berend?
Thank you very much for this very interesting presentation. Previous efforts at testing ex vivo and then testing in vivo have probably failed because they don't take into consideration the host and the tumor microenvironment. What do you think in regards to that and your technique?
Yeah, I mean, there have been so many different treatment platforms used, and I think they all have their peculiarities, right? In some ways, in the, I think, 60s and 70s, the field started with leukemia testing and on agar plates and these kind of things. And of course, now there's been a boom of organoid and organotypic spheroid type cultures, which are beautiful for research, but have struggled to show in any interventional and setting that they can actually help guide patient treatment. There are a few specific properties to the way we do things that aren't recapitulated by many of these other platforms. And one of them is indeed taking the whole tissue and then after analysis, seeing, was it cancer cells that responded or was it something else? Fibroblasts, mesothelial cells, immune cells, any tissue, whether it's a blood biopsy or solid tissue biopsy, are complex mixtures of cells. In the solid tumor setting, we do dissociate, but what you see in these images is that we maintain small tumor clumps. So these are really, like in many cases, tiny microspheres of solid tumor tissue. And then I think what for us is something that we repeatedly see is that it is really that ultra short culturing that minimizes the adaptation of these cells to the artificial culture environment. We're throwing medium at these cells that they will have never seen in a human context. We're spoiling them with sugar and oxygen and all of these things that in a physiological setting these tumors would never see before. And of course, the longer you start culturing cells, the more they have a chance to adapt to that. And especially if it's a proliferative platform, which all spheroid and organoid cultures are, you risk that you only look at the drug response of proliferating cells, and you lose the drug response of the non-proliferating cells. And I think clinically that's a very important aspect, because the easiest way for a cancer to avoid being killed by many of these systemic treatments is just to sit tight, not do anything, wait for the drug to go away, and then come back, right? So there's a mixture of those that I think of those features that act in our benefit, but the jury is still out. I mean, I'm not saying this is the best platform, and there for sure will be therapy types that we struggle to analyze in this very short-term cultures. For instance, thinking about checkpoint inhibitors, basically there's no chance. Like physiologically, it shouldn't work in this setting. There might still be interesting signals, but it shouldn't enact killing in a in vitro setting, right? Yeah. Thank you.
Okay, there's one more question. Wolf.
Yeah. I have one remark and a question.
Yeah.
Your EGFR mutated in a brain metastasis are most susceptible to treatment, but there's also clinical data that the response rate to chemotherapy standard is double as much with EGFR mutated, and I can show you the publication. So it fits to the view. My question is, how do you select the compounds? Or do you do also antibody drug conjugates or T-cell engager work, or are you developing that too?
Yeah, no, and first, thank you very much for that point. We would love to, or we'll try to find the references.
I'll give it to you.
Or if you could give them, that's amazing. There were actually chemotherapies in that panel, and I was like, why would the EGFR mutant be more chemosensitive? But that's very exciting to know. The question is an excellent one, and it very much depends on the context and the question of the project. If it's about individual healing attempts or interventional clinical studies where we want to be able to provide actionable data to the clinic, we cannot go screening exploratory compounds and compounds that are not approved in a clinical setting. It does not make sense because we'd be generating a lot of data, but the clinic couldn't use it, right? So if it's in an interventional setting, then very much we try to tailor to what the clinic can have access to and what the patient might feasibly get. In the small feasibility trial we did together with the Introduction.bis, we actually managed to get all those therapies reimbursed by the health insurance system. So that's, then we're screening less exciting compounds, but we're giving real feasible options to these patients. And I think that is very exciting. And that's also embedded now in the model of the RAPID trial, so that we're screening only AML-approved drugs and drug combinations, but knowing that for sure those patients should, in theory, be able to get access to the drugs. And then, for instance, what we did in the glioblastoma setting, there's a lot of drugs we could screen that would never be relevant for glioblastoma because they don't reach the brain. So what we did there was really look for drug repurposing opportunities of drugs that we know pass the blood-brain barrier. So there we collected this drug library of neuroactive drugs, antidepressants, antipsychotics, anti-Parkinson's drugs that have no earthly reason to have anti-cancer efficacy. And yet we could identify a handful of those and understand their mechanism that actually do. Antibody drug conjugates, bispecifics, and we have good experiences with those in the in vitro ex vivo setting already. And CAR-T is something that, for instance, in the glioblastoma setting, we have a few exploratory studies where we start to show this might be feasible in collaboration with Tobias Weiss, amongst others. And we have a project ongoing also to explore this in leukemia setting with Marcus Mantz. Yeah, so work in progress.
Okay, are there more questions? No more questions. We're also a little bit tight in time. So the very last question from my side, when are we going to see the final results of RAPID?
Well, as it goes, and don't tell the funder, I hope they're not listening, as it goes, recruitment is slightly lagging behind our optimistic projections. And give it a year.
Okay, sounds good. Let's start again after the coffee break. So as a first point, we want to thank our sponsors. You see the list of sponsors for this event. As always, it's not possible to have this kind of event without adequate sponsorship. I see there's also some credits from oncology and radiation oncology, no credits from neurosurgery or something like that. So we need to have a discussion with them for next time. Okay, so then we can go back to the slide we had before. And I'm really glad to introduce the next speaker, who is Helen Bulbeck. And that's already your first slide. I had the chance to have a look at your narrative CV. And what you describe is a story of becoming immersed in cancer. So you described that your daughter was diagnosed with a brain tumor and you were diagnosed with head and neck cancer. So it's certainly something you have witnessed, which has had a very profound impact. And you continue to describe yourself as a consumer, a disseminator of information, and the provider of a network and a community. I think that's a very interesting description. It makes me curious to see what you're going to tell us in your presentation.
Okay, thank you. Okay, so thank you for inviting me to talk today. I'm going to bring the patient experience very much into this room, I think, and explore some of the challenges that living with a brain metastases brings. I run a national brain cancer charity in the UK, but also support trials in Europe. I'm currently supporting about 80 patients with brain metastases, and we talk daily, so I understand the limitations. And I think to the first part, I'm going to talk about the challenges they face, but then also look at how can we support this group of people so that they have a voice in what is a very complex landscape, which was eloquently described by both Denis and by Berend in the first two talks. So there's a lot of talk around whole genomic sequencing, but I think science and medicine, and indeed the person living with the disease has a duty to understand the consequences of treatments that are delivered to them. And increasingly we have a thrust of integrated care systems, which is towards system-wide outcomes measurement, but there's a case to be made that this actually loses sight of what is key to this, and that's the person living with the disease and what matters to them. And I truly believe that stories are a really important thread that run through this, because there is no story to be told without the patient, and that we are the only form of data. And the value that we can bring to the agenda exceeds that of the purely clinical. And this will lead to better management of expectations. So patients like me will be able to know, to see what others are experiencing and how that compares to our experience. We'll become co-pilots in our care. We can improve our own experience of care. And having patients as co-pilots helps everybody to reframe the problems that we're living with. It will generate insights, shift dynamics, and change practice. So let's talk a little bit about Brenda. This is how Brenda described her diagnosis of brain metastases. She's a HER2 positive breast cancer patient, and 18 months ago was diagnosed with 12 brain mets. She's 44, she lives in Northern Ireland. Recently retired from the police force through ill health. She had gone back to work after her breast cancer diagnosis and was very keen to stay at work because that's what gave her purpose. She was told initially that she wasn't a candidate for SRS, but she equally didn't want whole brain radiotherapy because she had read about the side effects and the sequelae that this would bring. So she did her own research and managed to find a hospital in England that offered her CyberKnife, which she had in July last year. And I think that sense of deep-seated shame runs through so many of the interactions I have with this community, that there's something wrong with them, that you're inferior or unworthy. They find that clinicians tend to write them off. You know, that they all looked at me as if I was about to drop dead, but nobody had actually told me what was going on. So that deep-seated sense of shame resonates throughout all of our interactions. And I had a meeting, just a social group. We meet together once a month, and these were just some of the quotes, the sound bites that I took from it, that just make up your symptoms if you want to scan. The fact that there's no regular scanning program, please bear in mind that I'm talking about the UK here, not Europe at this point. So if they want to scan, if they feel something's not quite right, they don't feel at ease with something, they'll make up their symptoms. I was a breast cancer patient, now I'm a liver, kidney and brain cancer patient too. I'm constantly redefining myself. Joe, she doesn't have a whole body scan that does all of this every time. She has an individual scan for all the different brain mets. So she's permanently living in that cycle of scan and results. So the day-to-day interactions tell us that we've got a long way to go with supporting these patients. They experience loss of relational closeness and they become socially inactive because they tend to pull up the drawbridge. They're bothered by changes. They're bothered by the potential future disutility. They get guilty. They feel guilty at the distortion of family life, which they feel they have caused. The average age for the group I work with here is about 40. They have multiple cancer diagnoses, but also now with the brain metastases, the knowledge that there's going to be progressive neurological disease, and it feels very different. They're concerned with their vitality, with the limitations in their role, their emotional well-being, their mental health, their quality of life. And it matters to them because it's an important decision factor for patients. So the considerations of varying survivorship, variable trajectory, disabling complications in frequency and severity, the loss of identity and the life context, which brings about a lack of resilience and a lack of ability to cope. And my experience is that when you're diagnosed with any cancer, you cycle through fear, anxiety, sadness, and anger, and this is the second time around, sometimes the third time around, for people diagnosed with brain mets. And I think it must be even worse if you're de novo, where you still don't know what the primary is. So reactions tend to be unguarded and visceral, and every value and belief that has made us who we are comes into question. The challenges are significant. What have we learned from resilience research? So in crisis, so this could be one major traumatic event, but could also be the accumulation of minor stresses over a period of time. People do one of four things. They either succumb, so they're overwhelmed and they need extra intervention. They survive with impediment, but they emerge, they're affected and they're hurt by it, they're damaged. They recover and they show resilience, they bounce back. They're not permanently damaged, and resilient people know that suffering is part of life, and this stops them feeling discriminated against when tough times come. Or they thrive and they go beyond where they were before. The crisis and changes made enable them to flourish, and these changes become permanent and then become embedded in who they are, in their DNA. And that's what we try to do at Brace Trust. We put in interventions and support so that people can live their best possible day, no matter what the diagnosis, no matter where they're at in their pathway. And there are little tweaks that we can make that build up our emotional strength and capacity so that you can move from fine to flourishing, to empowerment and self-efficacy. But these are the challenges that we hear about. And this is about humanizing the research so that changes made can be meaningful to the people who are living with and dying with the disease. So this is the zeitgeist, and these are the themes from the conversation that I have with people living with brain mets. There's uncertainty around prognosis, unpredictable disease trajectory, mental incapacity through cognitive decline, lack of support services. You identify a problem, but actually you've got nowhere to go with it. The lack of evidence, and what there is tends to be very, very fragmented and sporadic. There's some sense of teleological time too. The census time is running out, and bereavement starts early on the pathway for the caregivers. I find that the average age is the mid-50s, so the issues take on a financial character. You may be at the point where you want to really advance your career to get to the top of your game. You're maintaining a home life, possibly with a mortgage. You're supporting children, potentially through education, and you'll find you have new obligations. You may be beginning to feel the pinch from older parents. So a metastatic diagnosis tends to hit at a critical time point in people's lives. And data has a key role too. This estimated incidence and prevalence of metastatic brain cancer in Northern Ireland was only published last week, and it claimed to be the first time there had been such an in-depth data resource there for people to use. So there is so much data around disease, but there's a black hole around brain mets. There's an opportunity here to truly value the transcendental nature of the importance of quality of life data, from the decisions that people make about their personal health to organisations like myself, like hospitals that are striving to meet their needs, and ultimately the governmental role in commissioning services so that we can assure that health and well-being means that it's essential to our approach, and that it's one of collaborative working. And our daily interactions with the people living with brain mets tell us, however, that the gathering of such collective intelligence is elusive, and this approach remains challenging. Having health-related quality of life indicators validated and accepted will help everyone to achieve better outcomes for all, for patients, caregivers, and service providers. For improved best supportive care, close collaboration is required between the providers and the clinicians involved in rehabilitation, supportive care, quality of life, the psychological and palliative care to plan for transition in points of care. And this requires complex coordination of different specialties and expertise, from symptom management to end-of-life care. We know too that there are issues at the point of diagnosis. We understand the issues around prompt, not early diagnosis. That's another presentation. But the nature of a rare disease means that unless a clinician specialises in that area of medicine, it can be a struggle to get a prompt diagnosis. Patients can have multiple visits and see a variety of healthcare professionals, which makes the pathway difficult to navigate. And very often people have to own that responsibility themselves. Primary care may be the first port of call, and we all know that in the UK it's really hard trying to get an initial appointment with your general practitioner, who may have limited knowledge. And at this point of diagnosis, you have to absorb a lot of complex ideas very, very quickly, particularly if it's de novo. Support must be available. You have to have signposting to trusted information, which I'll talk a little bit more later in a minute, and tumour-specific support groups. I think patients would expect that a multidisciplinary team would be involved and the team is suitably prepared so that the patient doesn't get results in a chaotic manner. And this is harder to manage as we have access to our patient records online now. And I have had incidents where patients have seen the results before the results have been mediated by a human being. We have to live with our conditions 24/7, and this enables us to be world-leading authorities on our diagnosis. Our voice is essential and central to planning research. We can bring patients closer to research and research closer to the patient. This is particularly relevant when you're living with a less common or you're part of a rare disease community. And the provision of real and virtual communities helps to shape and influence research and policy. We are an awesome force, so please use us. If we scale back from the patient now and look at the broader climate, we know that patients living with brain tumours, whether they're primary or whether they're secondary with brain mets, have a variable experience on the neuro-oncology pathway. There is a sense of being lost on the pathway with people living with brain mets. They keep saying, where is neuro-oncology in all of this? Because they still tend to stay with their primary cancer clinical team. And they would love to be able to speak to somebody in neuro-oncology. So it does need to have a multidisciplinary, adaptive and collaborative approach to improve the experience. It's a very complex landscape with all of these things at play. There's a lack of information. Patients may not have been appropriately informed about what to expect. They might have, this could lead to unrealistic expectations about things like waiting times, treatment availability, or complications of treatment, or options to have no treatment. They can have too much information. They might attend their appointment with a preconception of how they will be treated. And this might be because they base their expectations on pre-COVID systems remaining in place, or the experience of friends or relatives whose situation could have been very different, or their experience of what they found on Google. Time pressures. It can be very challenging to manage appointment time, spending sufficient time talking to a patient to check they fully understand the issues involved in their care, the potential complications of their treatment, or alternative treatment options, which is still a vitally important step. And then they'll bring heightened emotional states into the consulting room. And the complexity of interaction can create serious miscommunication, which in turn thwarts understanding the patient's expectations of treatment or involving the patient in treatment planning. It's hard to nurture hope when the future is bleak. So these are the non-negotiables that they've asked for, the community has asked for. What do we want? And this is for clinicians as well as patients. We know that new research paradigms are changing the way we collect, measure, evaluate, and act on the data we have, but this is still in its infancy, even more so with brain metastases. Many of the existing outcome measurements have not been designed for the sort of population level outcomes we need, nor do they reflect the local level, the subsets or key groups of patients, or even what matters to them. So the headwinds include access to local resources, to mindsets, both the patients and the clinicians they're working with. The human condition, it is messy when you bring humans into the clinical space. There's a shortage of resource. The research tends to be very fragmented, and there's a lack of funding. And then, of course, data. Analysing data in appropriate clinical, social and environmental contexts and drawing scientific conclusions which show validity. And then if you have the data, which instrument should you use? Which method of assessment? How often? What human resource do you need? Who's going to interpret the data? Is the difference clinically relevant? And then in treatments, you've got radiation oncology, which still tends to be one size fits all. And most efforts in improving radiation tends to be around technology. And the biology-based radiotherapy needs development too. So how do you begin to address these? Well, there's a huge role that shared decision-making can play here. The goal is to ensure that every person who needs and wants it has access to the shared decision-making discourse. This is the zeitgeist, because it drives involvement with care, it improves quality of life, creates better outcomes, and ultimately it will save money. So there's a health economic argument. But to deliver this, we need to invest in the capacity of patients to create value in our health systems. So you need prepared patients, you need supported systems in hospital, and we need to see resource investment in there. My own experience working with this particular community of people is that even within my own team, I've been aware of a nihilistic attitude that they're only going to live 3 or 4 months once they're diagnosed. This is not the case at all. The younger and fitter the patient is, very often they can live 3 to 5 years with a brain metastases. So there are 4 stages of awareness that shift the scope of a conversation with patients from individual reflection to shared insight. There's the concrete information. So in consultations, trying to elicit what the facts are, what's happened, tell me what you know. Then the emotive responses that you have to work through. So the feelings, what do you spend your time thinking about? How does it make you feel? And then their interpretation. This is where the deep grappling is done that will help them find meaning. What's this all about for you? What are our insights from this? And then the decision. So what implications, this is where implications and decisions are discussed. What decision is called for? What do you want to do? What are the next steps? Who's in your team that's going to help you achieve what you want to achieve? And there will be conflict. Oftentimes we're caught unawares. We had no idea. We felt strongly about a situation until the emotion wells up in us. But when handled well, conflict can become a positive experience. It can be a healthy friction that allows for innovation. And friction challenges the norm. It can build relationships and open opportunities. So aim to find the highest common purpose and build the solution backwards from there. So what would be a good outcome for you in this consultation with me today? How would this be time well spent? And then you can begin to explore options. You can either collaborate, compromise, compete, accommodate, or avoid. So what's so important to the patient that they won't give it up? And then look at our behaviour, which includes the patients as well as the clinicians, so that we can all dance in the moment and create the magic of the ordinary and let go of what's in our head. There are 2 things the patient wants to do, and that's value the real life experience and focus on quality of life. And if you just ask one question in the time you have with your patient, just ask them, what are you struggling with the most? And keep asking that question until they've surfaced everything that they're struggling with. And don't be afraid of the answer, because it's not your role to fix it. Just asking the question is patient-centered care, and it will elicit unmet needs. It shows empathy and understanding, that you're listening and that you care. So if you just ask Brenda, whose trust has broken down with her clinical team because they could only offer a whole brain radiotherapy. If you ask her, what does she need to be different? What does she want for people like her? What's a good result look like for her? You're showing curiosity. And if you take, don't be afraid of the answer, because it's not, as I said, it's not your role to fix it. And there are things that she won't be able to fix. But you could pick 1 or 2 things that she's struggling with and say, okay, what could you do about this? And that's shared decision making at its truest. Okay, so in terms of what we're doing, we're working globally with other patient organisations. We have extensive info. We're all aware that these individual organisations have supportive material that are trusted, they're validated, they're evidence-based, but they're fragmented and scattered. So we're pulling together a global hub, if you like, which is going to be an interactive repository for all of the information that's going to reflect the pathway. So they'll be categorized into preparation and awareness, assessment and communication, therapy, trials, well-being, and your future. We've made a start. We've produced that. I've just been diagnosed with a brain metastases, which is downloadable from our website. And I think ultimately it comes back to the story, the power of the narrative. So eliciting from the person living with the brain metastases what matters to them, what their values are, their context, their appetite for risk, would be a transformative conversation for them. It would place them as co-pilots in their care. They'd be regarded as an asset with their own sense of resourcefulness and range of capabilities. They'd be more able to talk about research and become involved with it. And they would recognise this as a person-centred process, so that quality of life becomes just as much a rich theme in the research as the search for a cure, which possibly isn't going to happen in their lifetime, but they would have a good story to share. And I think from the patient's perspective, it's about developing agency in people living with brain metastases. so that they have a voice. But we need the tools, the networks, and the license to be people first. And that's going to take a considerable investment in technology, new tools to aid decisions, and a change in a culture for everyone. We need to see influencing factors developing from a shift from passive participant to an active participant. We need to demystify the complexity and sophistication of the biology, the design of trials. We need to build resilience so that we're comfortable with uncertainty when we're living with the disease, which is not the same as feeling unsafe, so that we understand the risk, but we're able to bring our own context and values to the table as well. And we'd love to see a shift from randomized controlled trials to real-world evidence being used, from can it work to does it work, from ideal conditions to real-world conditions, from fixed regimen to flexibility and agility. It will be messy and broad because it involves the human condition. We need to gather data better, and we need to analyze and interpret data better and bring it back into the clinic. We need to create simpler online tools for busy clinics for collecting data, and we need to define the role of patient-reported outcome measures for people living with brain mets. So we need very much the experience to be different from what's gone on before, and we need the research to be defined not only by its ambition, progressive therapeutic thinking, and cutting-edge practices, but also by its kindness, empathy, and support. And we'd all like to have a role in the research. Thank you very much for listening.
Thanks for your presentation. Perhaps there are already some questions. There's no question, I would start.
I knew Michael would come up with one.
Michael, please. So you have precedence.
Thanks for making the journey. So obviously you alluded 3 or 4 times to all the deficiencies of your country, which we like to hear because we like to do UK bashing. But on the other hand, patient and caregiver perspective is so strongly represented in the UK. To what extent is that due to the poor health system that you have, and to what degree to the UK character of the people? Because you are by far the strongest country. Is it only because your healthcare doesn't work, or is it something in the British character?
I don't think it's because the healthcare system is broken, because, you know, our patient and public involvement started many years ago. And I think there is a true sense that working collaboratively, that, you know, the ethos, when none of us as smart as all of us, that actually there is a real drive to change the experience for patients. And I think the climate and the systems and processes that we have in place, which were initially done through the National Cancer Research Institute, have enabled people to have a voice. And we have a really good understanding of what that voice looks like and how it can be utilized. You have to be very careful when you're looking at, you know, you're working with patients and the public, because yes, there are patients that are stuck in their diagnosis and they're only interested in their story. So it's about bringing validation to the activity and making sure that it's rigorous. You're interviewing patients if you're going to be involved in a trial, to make sure that their motivations are altruistic and the right ones. And I just think we have a very strong legacy. We're determined, even though the National Cancer Research Institute no longer exists, we're determined to make sure it survives and has a legacy. Yeah. Eva.
Okay, thanks very much. So perhaps you are the next speaker, so you first need to get your technical equipment, and we give you the question in after that.
Okay.
So I will just use the time to ask my question now. So you said, and it was an interesting wording, I'm not sure I can recapitulate, but basically along the lines, there are patients who see the results before there's a human being who can mediate that. So what immediately sprung to my mind is there's a US law mandating that all reports must be made available to patients at the same time as for the healthcare providers. So what's your attitude toward that? Do you think it makes sense? It's a discussion we're having in Switzerland as well. Should this be a question of making it available as soon as possible? Or would you prefer to have a solution where it is mediated or explained by somebody of the healthcare sector?
Well, I'm the least process-driven person there is. I hate process in any form. But I truly feel, that it's almost too late to bring a law in that prevents that happening. And I think the best case scenario, and it will take resource, is about managing patient expectations so they understand they can go online and they might see their results that might be very clinical in language that they won't understand, but they need to know where they can go to have their learning scaffolded. So they need to understand that if they go online, they might see information they don't understand or that scares them, but if they do that, they need to know where they can go to get the support. I think it's almost too late. I think, we would say in England that horse has left the stable. Yeah.
I think that's a good answer. The only thing I'm worried about is if you see a result and you know where you have to go, there's still not being somebody there who now can give you some information on this, because the result will just, pop up and then it's there. It's a challenge. And,
it is a challenge. Yeah.
I'm curious to see how we're going to deal with it. So, okay, now let's go back to your question, please.
A very quick question, because we're running out of time. I didn't hear you much talking about how patients should be part of the design of trials, but I think this is happening increasingly, and I'm bringing it up since we have our EORTC authorities here.
Yeah.
We need to see more of that in brain tumors. I see a lot of that in breast cancer.
Yeah. And I'd love to get to the point where patients are actually designing the trials and bringing those to the table. So we have our patient research involvement movement. We have about 250 patient advocates that are trained in how to be on the trial management group. They understand the complexity of trial design. But you're absolutely right. And I think all patients should be involved, even in the design of the question and in pre-concept stage, all the way through the pathway to dissemination. Yeah. Thank you.
Okay, thanks again for the presentation. Now let's move on to the last speaker of this session, which is Evangelia Razis from the Hüllner Hospital in Athens. You're the director of the 3rd department of medical oncology. So I wondered how many departments of medical oncology you've got, but 6. Okay, well, that's fascinating. And we're going now to deep dive into more clinical questions, asking what are the medical challenges for CNS metastasis.
Good morning, and thank you particularly to Emilie, but of course also to Michael for this honorable invitation. I'd like to devote this talk to a very dear friend of mine who was diagnosed with brain metastasis yesterday. Early in the morning, I got a call. He has a brain full of mets. Conflicts of interest. This audience doesn't need for me to tell you that what brain metastases are, but just setting the basis. They're secondary tumors from another part of the body, most commonly from lung, secondly breast, and third melanoma, fourth I would say was renal. And it affects a large percentage of cancer patients, increasingly so as cancer patients are living longer and have the time to develop brain metastases, but occasionally they can be the first presenting sign, as in my friend. The most common presenting symptoms are obviously neurological, with headaches and seizures, cognitive or behavioral changes, balance issues, weakness, or sensory changes. And sometimes the symptoms are non-specific and are missed. So one has to be tuned in and think about brain meds when they're treating systemic cancer, and obviously order the appropriate imaging, of which the MRI is the gold standard, and the biopsy may or may not be needed depending on the primary and the most recent histology report and whether or not this is a first diagnosis ever. Clearly, also just setting the basis, the treatments are both local with surgery and stereotactic radiosurgery, and systemic. And we're hearing more and more about the efficacy of systemic therapies. We're also hearing new information about how it might be useful to use stereotactic radiosurgery before surgery so that you can decrease the risk of some of the complications, which you'll hear about in a minute. And it seems to be a more effective way to go. Now, surgery is appropriate in only certain settings, so we only refer to those limited settings where surgery can happen. And always palliative care has to be thought of, because brain meds are, after all, an advanced cancer setting where palliative care should be involved early. Now, one of the most important challenge is indeed the fact that brain metastases do recur frequently, and they have a rapid progression. When this progression happens, it might be difficult to differentiate it from radiation necrosis. The juggling of systemic therapy treatment with treatment for the brain mets may be challenging sometimes. And obviously, there's not always predictive biomarkers to know which method will be the best to treat the brain mets. Once a patient has developed brain metastases, they frequently have edema, and edema means steroid use, and steroids are awful drugs in some ways. It is quite common that patients will have severe myopathy, and if they've been on steroids for a long time, they can even develop bone problems. Besides the steroids, everyday clinical practice is full of the cognitive and neurological impairments caused by brain metastases and by the therapy, as we'll see. And one of the most important things that I think was also mentioned by Helen before is the actual lack of the ability to take care of yourself, your inability to drive, and therefore a lot of times that means inability to work, and a cognitive decline that comes not only from the disease but also from the treatments. Furthermore, systemic agents have CNS toxicity that deteriorates your overall well-being and compromises your independence further. Brain mets, as you just heard, have a very severe anxiety-provoking and depressing effect on the patient because the brain is conceived in our culture and society as something extremely central to our existence and to who we are. We are also, for the most part, aware of the fact that patients that have brain mets carry a poor prognosis, and that they may lose their ability to think. And those are things that, for most patients, are very severely depressing. Therefore, and as also was said a little while ago, access to multidisciplinary care is critical for brain metastases patients. They do need to know where they can find their neuro-oncologist, and they do need to know where to find psychologists, neurosurgeons, radiation oncologists, medical oncologists, the whole 9 yards. That is not always possible in all settings. I'm going to go through a quick case because I think it illustrates the next more important points I want to make. This man, who is a real patient, was diagnosed with lung cancer in April 2015, incidentally, when he was found to have 3 lung nodules, and was treated with postoperative adjuvant chemoradiotherapy, and was well from 2015 to 2018, where he presented with headaches and gait imbalance and was found to have 2 brain lesions, one in the cerebellum and one in the left occipital lobe. He had a PET CT, which was negative for other metastatic sites. And I'll tell you off the bat, he's still alive today, 7 years later, has never had disease below the neck, has only had disease in the brain. He had a surgical resection of the right cerebellar lesion because it was growing fast, followed by gamma knife in both lesions, and the pathology was confirmatory of the original histology. And then he recurred a year later, had another gamma knife. Further progression of one of the lesions led to surgery, and the pathology was only radiation necrosis. Because of fear of him developing more brain mets, he was started on nivolumab in June of 2019 and stayed on nivolumab for about 2 years, a year and a half. He stopped it because of intractable pruritus, itching. In December of 19, he had another gamma knife for progression of a brain met. And in January of 22, further progression led to another biopsy, which also confirmed radiation necrosis. And at that point, He was observed for a couple of months, but then he started losing his vision. Therefore, it was decided to treat him with bevacizumab for the radiation necrosis, which had now been confirmed twice histologically and seemed to be the one and only problem this man was having, who was otherwise very functional. In April of 23, after having bevacizumab, he had a progression that was resected, and this time there was both necrosis, but also hemorrhagic areas with live tumor cells. So it was decided to treat him with a targeted agent for his KRAS mutation, which is sotorasib, and he received that for about a year when he was found to have a new progression, and sotorasib was stopped. And till today, the major problem that this patient is facing is worsening vision. This completely disease-free from the neck down person has mostly lost his eyesight because of radiation necrosis, although also a little bit of disease progression at times. And I just want to underline how dramatic sometimes the interplay of disease and treatment-related problems can be. And with my friend Nicolaus in the audience, I hate to say that radiation necrosis is a bad problem, but it is. Some conditions increase the risk of radiation necrosis: lung adenocarcinoma, renal histology, ALK, HER2, BRAF V600 mutations, certain areas of the brain, the temporal lobe. I'm not convinced by the data, the subventricular zone, single fraction radiotherapy, higher doses, post-operative radiotherapy rather than pre-operative, like I was saying before, concurrent systemic agents. We'll see a little bit of that. Women seem to be a little bit more sensitive. This, for example, is a case of a 62-year-old woman with small cell. This woman had this radiated, the lesion became better after 3 months. At 6 or 8 months, she had a bigger lesion, which on perfusion seemed to be recurrence of disease, as opposed to this patient whose lesion treated with TDM1 for HER2-positive breast cancer in a young woman went from being with a high CBV score to a negative CBV score to being necrotic thanks to the TDM1 treatment. So radiation necrosis can occur, but it can also be necrosis because of systemic agents. We'll talk about this in a minute. It is a vascular tissue damage. It's caused by local ischemia and hypoxia. It leads to the increase of HIF-1A and VEGF, and that's why we postulated, the scientific community postulated that bevacizumab may work, and this is one of the early studies by Booth et al. That showed how radiation necrosis responded to therapy with bevacizumab. And this is a report that came to show that radiation necrosis, not only because of the radiation oncologist, but also by systemic therapies. It's a letter to the editor published in JAMA just a year and a half ago, showing that patients that get antibody drug conjugates, primarily for breast cancer, although as you see here, there are some patients with other tumors, have a tendency to develop radiation necrosis more frequently. Of course, this is retrospective data. It's from Memorial. And what you see here is that if you get the ADC concurrently, as opposed to getting it sequentially, you do have an increased risk of radiation necrosis, and that is true at all time points. So the increased risk remains as time goes by. This particular data was then canceled in a way by a new publication that just came out, I think, last month, from another group in the States, I think in Florida, where they looked at 34 patients with 250 lesions that were patients treated with TDXD and SRS. They didn't seem to have an increased risk of radiation necrosis. These data are all retrospective. They are data that are limited in terms of numbers of patients. The study from Memorial had 50 patients with SRS. The study from Florida has 34 patients. The prospective data from the studies that show the efficacy of TDXD in the brain studies that showed that unfortunately did not collect the radiation necrosis, or at least have not reported it so far. Now, brain mets is also leptomeningeal disease, and you have the expert in the room, but just to remind you that leptomeningeal disease has even more elusive symptoms than proper brain mets, has a very, very difficult diagnosis. Sometimes you have to keep tapping the patient if you're intent on getting cytology. Nodular lesions can obstruct CSF flow, and you might have to radiate for that purpose. And it's usually a very advanced disease state, and patient's performance status is compromised. Now, what about treatment? Treatment challenges besides radiation necrosis? Well, the blood-brain barrier, we hear about it. We heard about it a little bit before as well by our colleague from the pharmacoscopy field. Then there's a heterogeneity of tumors. Not all tumors are the same. Not all mets are the same, as we will see in a minute. And of course, we always have to remember, this is a brain met symposium, but the patient usually has disease elsewhere. Not always, but many times. And to make matters worse, there's this whole theory about the brain microenvironment and how it's immunosuppressive, which is partially true. It has a reduced immune cell infiltration due to limited T cell migration and low antigen presenting cell activity. The presence of immunosuppressive cells like microglia and tumor-associated macrophages is a problem, and they secrete suppressive factors. And tumor expression of immune checkpoints, it makes T cell activity even more compromised. However, we've seen from studies in melanoma that there is activity of immune agents in the brain. In fact, there are functional meningeal lymphatic vessels in the brain, high concentration of T cells and MHC2 expressing immune cells. There, compared to extracranial metastases, there's a higher number of neutrophils in brain mets and less TCR diversity. And samples from patients treated with immune checkpoint inhibitors exhibit an increased number and diversity of infiltrating immune cells. That means something happens when you give ICIs. The brain is not indifferent to it. And this comes with all these studies that have shown in melanoma activity, intracranial response rates, in some cases as high as 70%. Now, what about the molecular profile of brain mets? And then this was a seminal paper that had to do with the difficulties we have when we treat brain mets, that showed that there is branched evolution of metastases, and therefore the molecular profile of a brain met is different sometimes than the molecular profile of the original primary. And in work that we presented with colleagues in Manchester just this month, we looked at 800 brain mets that were sent off to Foundation One and compared them to 11,000 systemic disease primaries and other brain mets that were sent. And we see that the brain mets are enriched for different metastases. And what we showed is that there are more than 3% express certain mutations significantly different than the primary and the non-CNS mets. And we also found that there are significant targetable immune checkpoint and PARP inhibitor expressions, such as things that have to do with TMB and MSI. So all in all, the problem that we all face when we treat brain mets is the fact that there's lack of research, and I'm sure Emilie will talk about that. All these novel therapies that exist for systemic disease have not yet been exhaustively studied in brain mets. And there's very little study about the side effect mitigation of all these problems that patients feel all the time. In a report from Neuro-Oncology in 22, what we see is that industry-funded trials, cooperative group trials, enrollment in the remote past compared to the most recent past, and disease site are statistically significant factors about whether or not brain met patients will be included in the study or not. Things are, however, getting somewhat better. This is from a study by Aaron Tam that showed that amongst drugs that are approved by the FDA, the studies that were ran for the approval, for the most part, included brain metastases, but only very rarely did they survey patients without brain mets during the study to see if they developed them. All in all, the FDA has issued a guidance. Most of the people here would know that it's recommended to include patients with brain mets in studies, that it's recommended to include patients with active brain mets, and I'm sure Emilie will tell you what that means, and to include leptomeningeal disease, unless you are studying an agent that either will prohibit the efficacy of antiepileptics by lowering the seizure threshold, or will cause bleeding, or will affect the CYP P450 system. And the recommendation for baseline CNS screening is very strong, especially in populations where the risk of brain mets is high. So since that guidance, what we see is an increase in patients being included, but conditionally so, and a decrease in the patients being wholly excluded. So some progress is happening, as shown here. And this is the study that I'm sure will be shown later about what it means when we're talking about active brain mets, how unclear it is and how a relative concept it is and how it needs to be defined further. And my last slide, one last call that brain mets not only should be treated, but should also be prevented. And this is an expert consensus by a group of friends, including Emilie, about how and when we should at least consider preventing brain metastases in brain tumor patients. So in summary, I would say the early detection and of course prevention is critical. There are many treatment limitations and the quality of life is severely compromised. The focus should be obviously in being more innovative about our treatment, as we heard earlier with pharmacoscopy, and more focused on personalized medicine, and above all, to place importance in multidisciplinary care, as mentioned by Helen before. Thank you very much, and I'm open to questions.
Okay, questions? Okay, Emilie, please.
So thanks for the nice talk. Just a question, what is your opinion on this? Because you show a slide on how to combine SRS or with new drugs. Do you think we have enough data, or how can we implement that best without too much toxicities for patients?
Well, so I think you're very right. We don't have enough data. The data are not being reported. But what is happening is there is as you know, this attempt for a sequencing trial by the EORTC. And I think that is going to be critical. It's only going to now be activated in lung cancer, but we're looking for a good drug in breast. Because I think sequencing question will also answer this. You know, we'll see whether or not it makes a difference to give the drugs closely to the SRS or later, both in terms of efficacy and in terms of side effects. My opinion, just personally, is that if drugs are active in the brain, they logically would enhance also radiation necrosis, and we've seen this. We know that TDM1 is 13 times more likely to enhance radiation effects than is Herceptin, for example. So I tend to believe the first report more than the second one. And I don't think we have any real scientific basis as to how far you're supposed to be. You know, people are saying 2 half-lives or 1 week or 2 weeks, completely random, no scientific data. So I think even if you give it years later, you may see reactivation. And I have seen that. So I'm sure our drugs are doing something to the effect of radiation. It's not just the radiation. Thank you.
Hey, are there more questions in the room from the audience? We still have got some minutes, which is actually nice. So one question from my side: when we look at patients, for example, with breast cancer again, you know, and sometimes we do find tumor cells in the cerebrospinal fluid. On one hand, the prognosis of these patients is very different. So generally, it's pretty poor, but we've seen patients now going on for a very long period of time, and we are quite unable to predict this. So do you have any idea how we could get better at predicting this outcome? And the other thing is the question whether we should treat this, you know, whether we should give intrathecal therapy. That's also something we are discussing time and again, and that nobody seems to know really. So I would be curious to have your opinion on these two topics.
So the RANO LM group has done some work to categorize the prognosis of different types of LM, and it's a different thing to have the cytology than not. So if you have the cytology, that's worse. I cannot really tell you if we have any further predictive markers other than some HER2 positive patients are very sensitive to therapies. There was a report from Duke and Harvard showing, like at AACR this year, showing, I think, 9 cases who all responded with leptomeningeal disease, responded to T-DXd. But that's, you know, just real world data. So I cannot tell you that I know why some people live longer than others, but generally speaking, we do not usually use intrathecal therapy anymore. Occasionally we will use intrathecal Herceptin. We have not used intrathecal immunotherapy as is done by Priscilla Brastianos. Occasionally methotrexate, but for the most part we don't.
Okay, so I guess the jury is still out. Now, one more question, or everybody's very happy, everything has been very clear, so thanks again for this very nice presentation. And that's actually the end of this session, and I will hand over to Michael Weller, who is the chair of the second session.
Thank you, Andreas. We now move to the treatments, and usually we start these meetings with surgery. Now medical therapy was first. I think that's just coincidence. I think we have seen all this nice pharmacoscopy work. We know that immune checkpoint inhibition doesn't work if patients are on steroids. So I think the surgeons are safe for the next years regarding their role in the treatment of brain tumors. And these meetings are always a nice opportunity to invite friends. So Joerg Tonn is a very close friend of our department. He's a chair, or unfortunately now emeritus chair of neurosurgery in Munich. And he's one of the very few people who has a big role in the RANO consortium that is largely US dominated, but he has started his own group on the role of neurosurgery within RANO, with a tremendous success story that many people envy, I guess. And it's very nice that you came, because he just comes from Hong Kong and stepped by. I don't even know whether you were at home in between. Thank you for coming.
Yeah, thanks for this very kind introduction. Thanks, Emily, and thanks, Michael, for this invitation. And I'm very happy to be here. Also to share with you some ideas, and I just said RANO RESECT did deal with gliomas, but some lessons we learned can also intriguingly be transponded to when it comes to the study of metastases. So this is my disclosure, but there's another disclosure, and this disclosure is that I'm not a mathematician and not a math teacher, but unfortunately, there's a lot of math involved. You can say it's all math stupid, but at least it's a lot of math we have to consider. So when we talk about lesions in the brain. A lot of people talk about lesions and say this is a sizable lesion, this is a lesion of X milliliter, especially also in radiation oncology or surgery. So what's your educated guess when you have a spherical lesion in the brain with a diameter of 3 centimeters? What's the volume? What would you say? Just educated guess out of the gut now, without calculation. Okay, nobody wants to mention something. So it's 14 ml. So if you have a lesion of 3 centimeter in diameter, it's 14 ml. So if the lesion is 60% larger in diameter, so think about a patient who had a 3 centimeter lesion, now it's 5 centimeter. This is 60% increase in diameter. What's the increase in volume? That's even more important when you counsel patients in uro-oncology. What's the real increase? No idea? So now it's 65 cubic centimeters. So basically it's not 60% more, it's more than tripled. And if you double the diameter, it's the 8-fold volume. And this is underestimated in many instances when you counsel patients. Now, when it comes now to surgery, and think about this lesion 3 centimeter in diameter, and the surgeon had to leave a rim of 3 millimeter because it was highly functional area. He couldn't resect everything. And I think we'll hear about the techniques in the next talk. But for instance, his monitoring said you should not go into the real outskirts of this lesion. 3 millimeters left. Is this a good resection? How much is being resected? I want to hear some numbers. How much cubics or how much percentage? So there's still 7 cubic centimeters volume, and the extent of resection is only 50%. So whenever you thought this is a good resection with the 3 millimeter left, you've only taken out 50% of the tumor. And this is something many people underestimate. So when you now have the other lesion and you have a rim of 3 millimeter, is this better? Is this worse? Better resection? So the volume is 20 cubic centimeters still being left in. That's an extent of resection of 68%. So from the surgical perspective, this is the better resection because 68% resection is better than 49% of resection. But from the oncological perspective or from the perspective of the patient, it's much better to have 7 cubic centimeters of tumor instead of 21. So whenever you talk about extent of resection as something percentage-wise being taken out, this is not meaningful. It's much more meaningful what you leave behind, the tumor burden in the patient. It's much more important than extent of resection. So if you compare different extent of resections you've just seen, you may compare apples with pears. So now we come to this RANO RESECT Group, which is now a group of many, many sites, and the number is increasing. And I want to acknowledge the work of all these colleagues in the previous works and the works to come. And when it comes to terminology of resection, and we just had these examples of extent of resection, we just published a review about the last 6 decades of neuro-oncological studies, whether or not they dealt with this extent of remaining tumor or extent of resection. And there were over 1,800 studies being published in these 60 years. 173 were reporting on extent of resection. However, they used 18 different semantic terms to describe what extent of resection means. And if you now look at this green curve here, this shows that those with a so-called objective parameter of resection, the number and the amount of studies reporting this so-called objective criteria increased. But what does it mean, objective? This is the definition in large landscape studies about definition of resection, and the definition of gross total resection varies between more than 90% of contrast-enhancing tumor up to 100% of contrast-enhancing tumor, and even more so subtotal resection that varies between more than 80 and more than 40% of contrast-enhancing tumor. And it only refers to contrast-enhancing tumor. Why? Because you can see it easily. There's no mentioning of non-contrast enhancing tumor, and there is complete unclue about the role of the absolute residual tumor, which is never mentioned in these studies. So we embarked in 21 to kind of define categories of resection based on the residual tumor, not the extent of what's taken out, but the tumor burden within the patient. And these were our criteria. And you can see that only complete resection of contrast-enhancing tumor has evidence class 2. Everything else is more or less anecdotal. And when it comes to supramaximal resection, which is now being propagated by neurosurgeons, that you go beyond the margins of the tumor in gliomas and you resect more than the solid tumor volume, there at that time it remained to be defined what actually the definition and the clinical role of the supramaximal resection is. So we embarked on studying a patient cohort of over 1,000 patients in whom we had all this information. We had the clinical annotations. All of them were molecularly defined glioblastomas. We had the mutational status, MGMT promoter status. We had the volumetry of pre and post-op tumor volume. And we had, of course, the clinical data. So you see here in this cohort of patients, roughly 50% underwent a so-called complete resection of the contrast-enhancing mass, and the others had either some contrast-enhancing left, according to our criteria, less than 1 cubic centimeter of contrast-enhancing tumor remaining in the patient after surgery, was near total, subtotal was less than 5 cubic centimeter of contrast enhancing, and partial resection was everything which was 5 cubic centimeter being left inside or more. And biopsy was no cytoreductive surgery. And we ended up with 744 patients with IDH wild-type glioblastoma who all got the same aftercare after surgery. So all of them underwent radiation, and all of them underwent the so-called EORTC or STUP protocol, which is temozolomide concurrent to the radiation and adjuvant afterwards. And out of these 744, we had 356 patients with the so-called complete resection, so these patients had no residual contrast-enhancing tumor left, and some of them even had more resection than the contrast-enhancing tumor, so it was a supramaximal resection. And it turned out that there is a threshold of 5 cubic centimeter, which is prognostic for the patient. So when you have more than 5 cubic centimeter of residual non-contrast enhancing tumor, then you have a worse prognosis. And if you have more than 1 centimeter contrast enhancing tumor, else you have a worse prognosis. So this is now a prognostic factor which is depending on the volume of the patient has, so the residual tumor burden in the circumstance of a uniform post-operative treatment. And you can see here that for progression-free survival and overall survival, this is highly discriminative. And then we ended up with a 4-class tier, a 4-class scheme of resection, which means class 1 is no contrast enhancing volume at all and less than 5 cubic centimeter of non-contrast enhancing tumor. Class 2 resection is less than 1 cubic centimeter of contrast enhancing and or more than 5 cubic centimeter of non-contrast enhancing tumor. And class 3, and this is now the bitter pill for the surgeons, everything more than 1 cubic centimeter of contrast enhancing tumor is class 3. and class 4 is biopsy. And you can see here this translates in progression-free and overall survival differences. So you see that class 1 resection in completely similarly treated patients ends up with a median overall survival of 24 months versus 19 months in class 2, 15 months in class 3, and 10 months in class 4. So difference between 24 and 19 months, 5 months, any drug which would achieve this difference would be part of the routine treatment that would be approved. So in other words, whenever, and this comes now to studies, you have to balance, you have to stratify the different treatment arms in studies according to these resection classifiers. If you have an imbalance and you have, for instance, in one arm more class 1 resections than in the other, you may end up with invalid conclusions. And the RTOG, meanwhile, has adopted this classifier and stratifies all RTOG studies which are currently open according to this classifier in order to avoid imbalances in the different study arms within their studies. So we now ask ourselves, what happens if there are tumors without any contrast enhancement, glioblastomas without contrast enhancement, so the non-enhancing glioblastomas all being molecularly identified, and the same story held true. So again, if you analyze all these patients, then the threshold is 1 cubic centimeter of remaining tumor. Whenever you have more than 1 cubic centimeter left in, you had a worse outcome. So these different works, and also we analyzed the value of re-resection in glioblastoma accordingly, could be validated by other groups. So there appeared a lot of studies meanwhile which used this classifier and came to the same conclusions. And this is very valuable because then we have an idea that this information, this classifier really holds true. And it also asks the question whether this is representative and different people do these calculations, do they come to the same firm conclusions? And actually, this was a question we had been asked by the reviewers of our first paper. They said, how about the inter-rater variation? So we started and sent out anonymized imaging sets to all the raters and collected their values. And what came out is very interesting. There was a huge variation in the preoperative contrast-enhancing tumor volume. Even what you think is easy to measure, there was a huge variation in this pre-op volume. However, there was a very solid and robust database in the post-op volume, which again says that's another argument against extent of resection, because in this equation to calculate extent of resection, the pre-op volume is an important denominator. So in other words, when you have imbalances or a wide range in preoperative volume, you will get in the same patient different values of extent of resection once you ask different raters. However, if you embark on post-op volume, you get very robust data. Another argument in the future only refer to the post-op volume as being volumetrically analyzed. But is this all about we have to know? So you have here the example of two different patients. Number one is 48-year-old, the younger one, MGMT unmethylated, post-op Karnofsky is good, 90. And this is another one, 70-year-old person, MGMT methylated, which is biologically and clinically better, post-op KPF 70, which is worse than 90, of course. And you see here, this person on the left side has a resection according class RANO 1, and the other one had a resection RANO 2. So is methylated tumor better, more important even when you have a lower resection class, or is resection better although you have an unmethylated tumor? So we asked ourselves, can we use this for a risk stratifier? And we did a study with 770 patients in whom we had all these informations to do an integrative risk stratification. And as you can see here, resection matters a lot, KPS matters a lot, age and methylation status are interdependent. So if you go now hierarchical, you see that resection is better off than biopsy. Of course, KPS discriminates, and if you have a biopsy only, it's age, it's not KPS. And then it comes to the methylation status. So if you have an unmethylated status, resection matters more than in a methylated. However, then age comes to account if you end up with that. And if you now end up all these different factors here in hazard ratios, you can form 3 different risk categories, which are easy to denominate. And these different risk categories, again, in patients who had the same treatment, split the patients according to their risk for further survival, or the potential benefit of further survival. So we had the training cohort of these 770 patients, and we used the validation cohort of the Boston group, Patrick Wentz clinic, and the validation cohorts showed the same results. So we end up with a easy-to-use risk score with a 3-tier risk profile. Risk category 1 is low risk, 2 is intermediate, and 3 is high risk. At different points, you allude to the RANO resection class, the post-op KPS, which is important, much more important than the pre-op KPS, because when the patient is in a bad condition after surgery, he will not qualify for a very aggressive post-surgical therapy. Age at resection is important unless it's resection class 1, and MGM promoter methylation is important as long as it's not resection class 4. And this is true for the cumulative risk in patients being treated with a standard protocol, the EORTC or STUP protocol, and also alludes to all other management approaches. Even if patients were management other than the standard EORTC trial prescription, then the same held true, that the risk category is related to survival. And our risk classifier, when compared to other risk classifiers which had been published in the field of gliomas, held true in comparison to different values of accuracy in the prediction. It was favorable compared to the other one. So how can we transfer this to brain metastasis? Is this transferable at all? Of course, all these volumetric analyses and the issue whether extent or volumetric analysis is important, that you can for sure transform. The other thing is that metastases are not very well prescribed lesions. There is some invasion pattern in human brain metastasis. This was one of the first elegant studies referring to that. This is a study from Anja Berghoff from the Vienna group. And we know, meanwhile, that metastases have a close interaction with their surrounding. It's not only that they are sitting there, they interact with the different cells, and this is more and more this tumor microenvironment interaction, which we know very well now from the gliomas, is also true for the metastases. And obviously, there is a value for complete resection, but this is not enough. This is a very elegant study from the MD Anderson group in 2017. Prospectively, they randomized patients in whom the brain metastasis was completely resected. The post-op MRI showed no residual tumor, and they were randomized into observation, which is the green light, or post-op stereotactic radiosurgery of the resection cavity. And as you can see here, the freedom from local recurrence is much higher in the stereotactically irradiated cohort compared to observation only. So obviously there is tissue left, despite the fact the post-op MRI didn't show any. So, and this tissue does form local recurrences. And freedom of distant brain metastasis was similar in both groups, which is clear because this was only a local control of the locally resected brain metastasis. And we know that patients need local control with brain metastases, but they will eventually die from systemic progression. How about the literature in supramaximal resection of brain metastases? We searched that in gliomas. There are 37 papers dealing with so-called supramaximal resection, which would be the consequence of the study I just showed you. However, in brain metastasis, it's only 6. And I would be very interested, we discussed this in the coffee break when we saw the Pharmacoscopy talk today, if we do a supramaximal resection and we send you the tissue, not only of the brain metastases, but separately from the supramaximal resected tissue, which we think is, at least from our surgical microscope, tumor-free, what the results would be, whether there's any difference. That would be something I would be very interested in. So supramaximal resection of brain metastasis is still a wide structure on the landscape. There are no systematic studies in brain metastases yet. I think it's important. The only one which gives indirect hint is the one I just showed you. So to conclude up, there is a need for volumetric analysis, which is key for studies dealing with the relevance of post-operative remnants in brain tumors. And this is, for my belief, true not only for gliomas, but also for metastasis. However, belief doesn't count. We have to show this in studies for the metastases. The post-op tumor volume in cubic centimeter is more relevant, of course, than the tumor reduction in percent in gliomas. How about in brain metastasis? And specifically for the brain metastasis, does the denomination no remnant, any remnant, provide enough granularity in brain metastases? I think that's also a question which resolves out of the MD Anderson study. And surgery may provide control of local disease, but we all know overall survival is dependent on the control of systematic disease. And systematic and well-controlled studies to evaluate the value of supramarginal resection for brain metastasis are in need. And I think the next speaker will allude on this subject as well. So with that, I would like to thank, and I'm happy to take questions.
No question. So when I looked at the score again, from the EORTC perspective, it would be something to stratify, right, for clinical trials, because in the end, you want to sell the story that this all makes sense, not just to publish, but to improve clinical trials. On the other hand, you have the KPS cut off at 80. Do you know how many were below 70? Because for a clinical trial, you would have to recalculate, right, if you wanted to use that for trial planning, because we would not include patients below 70.
Actually, the majority of patients is above 80 after surgery. So it's roughly the percentage, if I get your question right, the percentage between 70 and 80. That was your question. Because we could have done the calculation with 70 to meet the criteria of clinical studies. I think it was like less than 10%.
So it's not a lot below 70.
It's not a large one, but we may recalculate it, and I would personally favor to have the data of some studies, some clinical studies, and just to make a calculation on the study data, provided that we have also the imaging of these studies.
Yeah, but this is something we could discuss in the coffee. Yeah. I think for the proteasome inhibitor trial, we should have the data.
Yeah,
that would be nice.
And we could do a mock calculation to see how the differences are when we take 80 or 70.
Yeah, and I think
close to the clinical situation.
And then I thought maybe you have to calculate it also taking out MGMT, because I'm not sure that the community is ready to give up stratifying for MGMT as a separate factor, but maybe we can recalculate it.
Yeah, but that was only for that particular, and it's only, I think it doesn't matter for any drug which is independent for MGMT. But the other thing, basically, when it comes to the remnant volume per se, I think it's important in the future to stratify those who are class 1 resected, class 2 versus class 3. Otherwise, if you have a mixed bag and in one arm you have a lot of grade 3 resections, then you may have the worst outcome in this cohort, regardless of your treatment.
And we probably, just a second, Nikki, just the last thought. I mean, do you think, or have you discussed it with somebody like Thierry Gorlia? Every stratification factor is driving patient numbers. If people would buy into your score, it would be just one stratification factor. I'm not sure we could cut patients, but we could discuss that.
One should discuss it, but Denis Lacombe was very convinced, and he kind of propagated it for the RTOG. They do it right now. Sorry, Nikki?
Yeah, I was thinking along the same lines. You could even reanalyze the previous trials and see whether they would have been positive if the patient would have been stratified by this. That's what you just mentioned, that you may have an imbalance.
That's what we now like to do, have access to former trials and recalculate and just to mimic that.
Would you like to make a comment about this theory of radiating before resection? Is that something that would make an adequate resection easier, more difficult?
I think personally we had so-called failures of radiosurgery, which we then operated on. Actually, sometimes the delineation of the rim of the resection margin is a little bit more difficult. But if you are in an area where you can supramaximal resect it, then you're safe. But then, of course, you have done a supramaximal resection, which might per se be more effective. So I think that there's one question, one study, to my knowledge at least, which is now randomizing pre-surgical radiation versus surgery plus post-surgical radiation. And I'm convinced it could lower the rate of local recurrences if you do pre-surgical radiation. Yeah, and I'm not so afraid that it's more difficult to operate. Many of my surgical colleagues say, "Oh, don't radiate; it's so difficult to operate." No.
I would also ask about the surgical aspect you mentioned regarding supramarginal resection, not so much in brain metastasis, but in gliomas. How do you envision this will be achieved in the future? So is it just like imaging based, just the flare hyperintensity, or is there any role for intraoperative diagnostics, tissue diagnostics, or take out the anatomical lobe?
Yeah, there's not a lot of things happening now that intra-op imaging or intraoperative tissue analysis helps you to determine whether you are beyond the border of the solid tumor. We all know that there are single cells all over the brain, but you're beyond the border of the solid tumor. Number one is TERT analysis, has been recently published. Another, of course, is Raman spectroscopy, which is now being addressed in a systematic way in the United States and in Europe in prospective trials. I think there are other means which should guide the surgeon in the future, despite the fact that there's no tumor visible. There's still now a border where you should proceed to resect or you don't. One word of caution is, and the same we had with the ALA when we kind of developed this fluorescence guidance. When you resect everything which is obviously tumor, you should avoid to resect functional tissue. Because in all these studies, whenever the patients did worse after surgery, they had no benefit. And that was the case with the re-resection, supramaximal resection in recurrent glioblastoma doesn't make sense. These patients were worse because of the high amount of urological malfunction.
Okay, thank you.
Thank you.
So we stay in the field of neurosurgery. Stefanos Voglis from the local department of neurosurgery is the next speaker, and I think it's easy to predict that that is going to be a plaidoyer for gross total resection.
So, hello everyone, dear Emilie, dear Professor Weller, thank you for asking me to give a presentation about the neurosurgeon's most beloved topic, evidence for gross total resection of brain metastasis. Since the evidence overall is quite limited, as you already heard from the previous speaker, I wanted to put it a bit into perspective, into surgical perspective, and talk a bit about the indications, traditional indications for brain metastasis resection, but also about its safety profile nowadays, which old and already established tools are available to guide brain metastasis resections, and which new tools might be important in the future. And then give you a brief overview about the existing evidence for gross total resection in brain metastasis, and probably which other indications might be important for neurosurgery and brain metastasis in the future. So the classical or traditional indications for surgery were mainly comprised of single lesions, 2 to 3 centimeters and larger, then in cases where no histopathological diagnosis was yet present, and last but not least, in symptomatic lesions caused by the lesion itself or by the edema. And I think it might sound trivial, but the last point might get more and more important in the future, because there are studies that by improving functional status in those patients, this might facilitate further treatments, especially systemic treatments, which can make a difference, at least in a subset of those patients. Other indications for surgery, which the talk will be later about, is like the total tumor volume reduction in those patients. Does it matter in terms of survival outcome? Then tissue for molecular analysis, new tools like the pharmacoscopy drug screening, but also for the mutational profile testing. Does this play a role nowadays or in the future? And then obviously the reduction of steroid dependency in patients who are or who can get immune checkpoint or immunotherapy afterwards. And there's a bunch of other treatment tools we can offer from neurosurgery, like local catheters for intrathecal therapy or for hydrocephalus, but also all the tools from functional neurosurgery, which are currently investigated, like laser interstitial thermotherapy or high-focused ultrasound, or even intraoperatively administered radiotherapy, which I will not focus in this talk. So maybe to step back, to take one step back from a surgical point of view, the resection of gliomas and brain metastasis do matter a lot, and because I want to come later to the safety profile, just to remember, glioma is way less demarcated, also not only when looking histologically, but also under the operating microscope. It's more infiltrative, and it probably needs more experience to operate deeply located or eloquently located gliomas. In contrast to that, brain metastases tend to be well demarcated and not easy, but probably easier to operate for experienced surgeons. And we saw this talk here on this paper on the right from Professor Tonn previously. We know in gliomas there is distant infiltration, but also in brain metastasis, at least a subset of lesions do infiltrate the surrounding parenchyma, but this infiltration is much more limited compared to glioma, so it's way less than 1 millimeter infiltration of the surrounding brain tissue. No surgical talk, obviously, without some pre- and post-operative images, so we would argue that almost every location of brain metastasis is accessible nowadays with microneurosurgical techniques. So here you have some examples of lesions in the precuneus, for example, one in the insula on the right side, even one in the brainstem, one in the left thalamus. So basically, because they tend to be easier to operate and better demarcated from the surrounding tissue, it's also easier to operate them in deeply located areas within the brain. Now, what is the safety profile of neurosurgical resection nowadays? One of our residents, Louis, he looked into our prospective database, and these numbers are very much in line with other recent reports and studies from other centers. So the adverse events rates were like below 10%, 8%, but those included any adverse events, so even mild ones. And the rate of severe adverse events, meaning the need for a reoperation or the need for a prolonged ICU stay, were below 2%, below 1% mortality and 2% of permanent neurological deficits. And what we found interesting, besides known risk factors for new adverse events or new neurological deficits like eloquent location, that the deep anatomical location of brain metastasis was not necessarily associated with more or severe adverse events, which is a bit in line with our philosophy that if one wants, almost all locations are accessible with microneurosurgery nowadays. So what about multiple lesions? We heard in the previous talks that many patients present not only with one, but with multiple lesions, and the data on the safety of resecting multiple lesions within the same surgery is very limited because it's very rarely done. You have one example where the patient was repositioned during surgery and both lesions were accessed with two distinct craniotomies, so skull openings. However, there are some single center or dual center reports. And again, those are all retrospective reports. But in the end, what I would argue, I mean, the longer you operate, the bigger the skin incision you make, the more openings you drill into the skull, ultimately your adverse events rate and your complications will go up. But what these studies at least show that it does not exponentially increase. So I think there might be a role for very distinct and selected patients to resect more than one lesion when it fits into the overall oncological concept. So just a few words about maximum safe resection, which tools are available nowadays. Obviously skills, experience, knowledge and training, and then all the other technical advancements in the last years, which are basically nowadays in most centers used on a routine clinical basis. So from neuronavigation, ultrasound, even intraoperative MRI, fluorescence, neuromonitoring and awake surgery. What new surgical tools are on their way or are currently investigated? There are obviously many different tools, but I think the spectrum of intraoperative tissue diagnostics, especially when it comes to maximum safe resection or better resection results, is probably one of the most interesting ones. One is the previously mentioned Raman histology. Just very briefly, it gained a lot of attention in the last years. And what I found interesting is that, for example, the foundation model they presented last year, which was primarily trained on high-grade gliomas, generalized so well that it also predicted residual tumors in brain metastasis sample, as you see here in an example picture. So it really could demarcate the residual tumors in the surrounding brain, healthy brain tissue. On the other hand, there's nanopore sequencing, so PCR-free sequencing, which was also already shown to be feasible to be included in a routine clinical workflow. In the end, I mean, we will have the talk later about the role of DNA methylation profiling in brain metastasis, which I'm very much looking forward to. In the end, just from a surgical point of view for the both technologies, so the one probably could really help the surgeon to detect residual tissue at the tumor margins. Then again, the question is how relevant is this in brain metastasis, since we know the infiltration depth is much more limited compared to primary high-grade gliomas. But overall, both technologies probably will develop in the near future, and to be really integrated in a surgical workflow, they need to be really fast and probably also requiring as few tissue manipulation or pre-processing steps as possible. So that's That's apparently a very interesting field which can change our surgical practice. So now, what is the evidence for gross total resection? And in this context, with gross total resection in general, we mean the reduction of total intracranial tumor volume. So gross total resection, in the review Vittorio Stumpo, one of our residents, did, is defined as no residual tumor postoperatively, but we also tried to figure out which studies, for example, in patients with multiple lesions, didn't look only at the targeted lesion, but at the total intracranial volume from all lesions, so at the intracranial tumor burden, if you want so. So in total, over 4,000 articles were screened about this topic and its association with overall and progression-free survival. And in the end, 39 studies were included, which met our inclusion criteria. They all were retrospective, and only 3 were multi-center. The rest were single-center studies. So you already see the data on brain metastasis, and the survival value of extent of resection is very limited. However, he performed random effects meta-analysis anyways for gross total, so no residual volume versus subtotal resection and overall survival from all the studies which included hazard ratios or reported hazard ratios in a multivariate survival model. And you already see that out of the 39 studies, even the statistical reporting was not sufficiently enough to really gather the data to do a proper meta-analysis. However, from this limited data, he indeed could see a beneficial, so 0.67 hazard ratio, which indicated at least some trend to better survival in patients where gross total resection was achieved. But now all the limitations. If you look at the primary tumors which were included in all the different studies, here color-coded the absolute and relative numbers, you see that in green, the majority, almost 50% of patients had brain metastasis from lung cancer, from lung tumors. And I think this is quite surprising, because when we think back to the previous talk in gliomas, probably we are not one step further, but multiple steps further. We try to assess the extent of resection not only on primary brain tumors, but on molecular subtypes, and there are even reports on DNA methylation subtypes and the value of extent of resection there. And here in brain metastasis, it's quite hard to find studies which only focus on one primary tumor. For example, here on a study level, so each row is one study. On the left side, absolute numbers. On the right side are relative numbers. And you see, again, color-coded, most of the studies included a vast diversity of primary tumors and analyzed them all together. So what else? Some characteristics of the studies. Just mention a few. So each line again is one study, and the black dots is whether this characteristic was present or not. And you see that 9 of 39 studies were focusing on single entities, as mentioned previously. Then only 29 of 39 studies were reporting systemic treatments, which is also not, I think, which is also not a lot when you look at the inclusion timeframes, and at least some of the studies included patients in recent years. So at least in theory, some of those should have get targeted therapies or immunotherapies, and unfortunately, many studies did not account for those treatments as confounding factors in their analysis. And only 2 of 39 studies were reporting steroids at all. And that's, I think, also a big question, whether all this gross total resection or extent of resection or residual volume is an epiphenomenon for at least in patients who are under immune checkpoint inhibition postoperatively for steroid dependency. So to sum this up, retrospective studies, there's a big heterogeneity, primarily, but not only when it comes to primary tumors. There are, if you look at the studies which only included single entities, conflicting results, for example, for the lung brain metastasis, for others, for example, melanoma brain metastasis, at least the 2 studies which were only focusing on those showed both that there might be a survival benefit in greater extent of resection or less residual volume. And most of the studies insufficiently were accounting for systemic therapies, steroid intake, but also other confounding factors. What other indications might be important or gaining attention in the future? We heard a lot about tissue analysis for molecular profiling, and we also heard about the Brastianos paper. The question, I think, in the end, I mean, from a neurosurgical perspective, sending tissue is never a problem. What I was asking myself, is this really relevant in clinical practice? Or how often do we really do the mutational profiling in brain metastasis, and does it really alter the clinical decision making? So that's probably one thing one should look into. And the whole story about faster steroid tapering, what I mentioned before, whether the extent of resection or the more extensive resection is just a proxy for postoperative steroid dependency. And at least to this regard, there are 2 papers for melanoma brain metastasis, which indicated some signal that in immune checkpoint inhibitor naive patients, which were first resected and then received immune checkpoint inhibition, they had a better survival and a better local control. However, the steroid doses were not reported in every study. So as a conclusion, I would argue that microsurgical brain metastasis resection nowadays is a very safe procedure with a very controllable safety profile, and that almost every anatomical location is operable or approachable with nowadays tools and techniques, and the evidence for overall survival benefit in gross total resection or greater extent of resection or less residual volume to stay in the correct terms is there, but the data quality is very limited, and future studies should focus on single brain metastasis entities and account for the most important confounding factors in this multidisciplinary treatment field. With this, I come to an end. I'm happy to take questions.
Interesting. Surgeons never run over time with their presentations. When I looked at your extensive analysis again, I wondered a bit whether looking at overall survival is not too much of a moving target, because, I mean, the medical oncologists may be spoiling your party, because for some cancers, lung cancer, melanoma, they really have good treatments now. So have you looked at a time bias that maybe 20 years ago surgery was more important than today with all the good treatments around?
So we haven't looked at this yet, but I think it's a very good point. However, most of the also recent studies, surgical studies, always had overall survival at the end point. And I mean, that's, I think, really the problem with when it comes to analyzing the surgical value in terms of outcome in brain metastasis, that it's so diverse regarding treatments and so on. I mean, to get a cohort like Professor Tonn presented previously, where you really have same treatments and like same diagnostic and follow-up steps, it's, I think, really, really hard in brain metastasis.
And the other factor, I mean, that's also something for medical oncology. Maybe, I think, if you have good treatments, like take EGFR mutant, maybe you get the patients later, because the medical oncologist will first use their TKI repertoire. So maybe the time point of brain mets is also later, and that has an effect on survival analysis. Just a thought. Who was first? Nikki, I think.
Yeah, I was surprised to see that the literature, which is mostly retrospective, shows an overall survival benefit, because we have prospective data, and Professor Tonn showed it, where we have resection versus resection plus radiosurgery, and basically overall survival is identical. So personally, my first step, and this is what I suspect also for primary radiosurgery, I think my first suggestion would be to look at the overall value of local control at all, because that's what it boils to down. So if local control has an effect, you need to show when it kicks in. So for me, patients who only survived by a year will not benefit from optimal local control. So just beyond 1 year, you would need to look how is the effect of patients who have a local recurrence versus patients who do not have a local recurrence. So does this affect overall survival? And we actually modeled this not for brain metastasis, but for extracranial oligometastatic disease. So my first guess would be to model whether local control matters at all, because that's gross tumor resection versus subtotal.
First of all, thanks for this excellent presentation and analysis. So I think, and goes to the same direction, I think our first goal is local control, to achieve local control. And also in the combination, you briefly announced that we combine surgical resection of a large lesion and then maybe radiosurgical of some other smaller lesions, where we just achieve local control in order to allow the patient to re-enter protocols which stop once you develop brain metastases. But once local control is achieved, they can come back to these protocols and get another treatment. So I think this is actually what we should target at in the future, despite the different systemic therapies Michael was alluding to.
Matthias.
Thank you. Excellent presentation. I was not really surprised that there was an overall survival benefit, because, I mean, isn't it just an effect of tumor burden? If you have a small tumor burden, you can achieve a gross total resection. If not, so is it the intervention effect which you have evaluated, the surgical procedure, the local procedure, or is it just an effect of having more and larger brain mets, which you saw as an effect on overall survival?
I think it's a very good point, because there are certain studies which are only looking at single brain metastasis entities, where they looked at the residual total volume, especially in patients which have more than one lesion. And I would argue there might be differences between the primary tumors, because as far as I know, there are also there's apparently some data on extracranial tumor burden for patients with checkpoint inhibitors, where it matters for the checkpoint inhibitors to really function and show some response, how much tumor is left in the body. So the question is whether this concept can be at least translated to some brain metastasis entities as well. So does it matter also for the systemic treatment how much tumor is left in the brain?
Yeah, but
if the microphone is gone, beyond volume, but also location. I mean, if you would have a really eloquent metastasis, eloquent location, that might also affect survival, because you can't resect it maybe with radiation. Is it just patient selection which you see in the effect? Not so much the intervention.
Yeah, that can be, yeah.
On the other hand, it's all patients that had an intervention, right? Because there is no non-operated patients in there, right? So just to defend it a bit.
But I think, going back to your question, the overall survival benefit, if you analyze these studies, mostly is due to the fact that after resection of a brain metastasis, the patient re-entered
get treatment,
another systemic treatment. So if you correct for this factor, then you see there is a selection bias, because those patients, of course, have longer overall survival. So you should compare those who have the similar treatment after surgery, and then you end up.
Okay, I see no further questions. Then I would like to thank you again for this presentation, also for the excellent cooperation that we enjoy with your department. and we go to the coffee break a few minutes early.
Over to the next speaker, Nicolaus Andratschke, Leitender Arzt here in Zurich and the radiation oncology. Sometimes we fail as a local discipline. We see tumor recurrence in field, and then the question is about re-irradiation. So, Nikki, we're looking forward to your talk on re-irradiation in the same space, but also if there's recurrence at different locations in the brain.
Thank you very much, Matthias, for the introduction, and thank you very much for the kind invitation. Questions, I'm not sure if I can answer the question how far we can go, but I think I can step back one step and maybe discuss what is re-irradiation. And actually, I would like to allude that with an example, a general example from the extracranial space, and then move it to the cranial space. So we set out to illustrate what does repetitive irradiation mean. And even if you think of our previous talks, so there are different clinical scenarios that we need to consider. So the first one, and this is the one we consider a type 1 re-irradiation, is the one where the re-irradiation really happens in the same area where the patient had been previously irradiated. So there's an overlap with the previous irradiation. Most of the time, this is what we call a local recurrence into the radiation there. But on the other hand, we can have situations where we irradiate in the same area and have lesions close by. So there are not local recurrences, but new occurrences of tumors, metastases, or secondary primaries. And then at some point, the overlap of the dose gets critical, and we need to consider this. So this is what we consider re-irradiation. And from that, we differentiate repeat irradiation. And repeat irradiation is just a repetitive process of radiotherapy where there's no concern of toxicity, and no concern means where the concern is obvious, meaning an overlap. So thinking of like an organ like the lung, we have different lesions, and over time or at the same time we irradiate several areas in that organ, and then we have the so-called repeat organ irradiation. And if I transfer this now to the brain, we see here now a situation, and this can be a brain metastasis that has been treated here in the frontal area, and at some point later confirmed by imaging primarily, so hardly by biopsy confirmation, we have a local recurrence in this space. So that would relate to typically a type 1 re-irradiation. If it's really a metastasis developing close by and there's an immediate overlap, we would also call it type 1 re-irradiation. But this we have seen in the previous talk, this repetitive cycle. So this life cycle of patients repeatedly coming with newly developing brain metastasis. And here we irradiate different areas over the brain, which we formerly, as we heard, would consider a rather safe option for repeat irradiation. But then we come back to the type 2 re-irradiation. In this situation, at some point, we will have accumulated so many different lesions, so many different areas that the overlap of the dose might truly be a problem. So it's not always about the mean brain dose, as we have heard. So that's more the dose that's spilled over the brain and relevant for neurocognitive function. But then we're really talking about dose, locally accumulated dose in the brain parenchyma, which could then lead to radiation necrosis and really radiation damage to the brain parenchyma, and then functional deficits that are really othered. And I would like to first show a case of a type 1 re-irradiation, and it was a 60-year-old lady with an adenocarcinoma of the lung, originally locally advanced, node negative. She got operated, and in parallel, she had brain metastases, which were treated with radiosurgery. And the patient had the respective adjuvant chemotherapy, but at that time there was no driver mutation, and the PDL status was around 10%. So on the brain radiosurgery, initially it was a ring-shaped lesion. The patient had a very, very good response. You see this small contrast-enhancing spot, but later on, she developed again a ring-shaped reappearance of this contrast enhancement, and the PET was suspicious of a recurrence. Patient was presented in a local tumor board, and the further treatment and salvage discussed. The patient had no evidence of disease extracranially, so the MDT recommended again a local ablative treatment, and in this case it was voted for re-irradiation with radiosurgery. But we had the discussion about what is a recurrence and what is a radiation necrosis, and of course we also discussed what imaging or what type of imaging we would need or we would use. But there we certainly have equivocal cases, and this I wanted to illustrate by showing those curves. So if we look at the time interval, local recurrences develop. And here, this is shown from our own data where we analyzed patients with a smaller or larger brain metastasis and a cutoff was around 1 cubic centimeter. We see that we have really excellent local control at 1 year with smaller lesions over 90%, and then it drops down to around 85% and drops further down to around 80% at 2 years. If we now contrast this with data I've taken from that publication on radiation necrosis, and here the colleagues separated it by the size of the irradiated lesion. So the larger the lesion, the higher the risk of radiation necrosis, and the longer the interval, the higher the risk again. So basically, what we see here on those curves, we have a similar risk rate and factors associated with radiation necrosis as for local recurrence, and the time interval, so the longitudinal time interval is basically similar. So from a clinical point of view, both events are possible, and sometimes if we have equivocal cases we cannot solve with imaging. We either do follow-up scans, or if the lesions are easily accessible, we really urge our surgeons to get histology proof of what's going on. Now, if we look into the literature on what's available on re-irradiation and data on that, we have to confess that most data is really retrospective. So there are some prospective studies on re-irradiation in general, but not for brain metastasis. And if we look here, those series are rather small, like between 40 to 100 patients, and at most like 120 lesions. And this also makes modeling then quite difficult. And there are only a few works who really achieved to use the data to model on that. Most of those patients had lung melanoma or breast carcinoma. That's quite typical. The second dose of radiosurgery in most cases was also single fraction radiosurgery, but you can already appreciate that after single fraction radiosurgery, a lot of groups tend to fractionate again, and this is dependent on the volume of the reappearing lesion. The interval was roughly around 1 year, which is also reasonable with regards to the efficacy of radiotherapy. So there is an overall consensus that within the first 6 months, a re-irradiation should be really cautioned because on the one hand, there is not a lot of recovery to be assumed in the brain parenchyma first, and second, if the first irradiation didn't really work out to have a local control for 6 months, it's not considered oncologic infective. So 1 year is a reasonable interval, and we will see that this also has a predictive or a prognostic relevancy. The lesions were rather small for re-irradiation purposes, around 1 to 2 cubic centimeters. And more importantly, the local control was quite good. So normally we would expect a 1 year local control rate for lesions around 1 to 2 cubic centimeters, about 90%. But here we see that the local control levels out at around 75 to 80%. And this has mostly to do with the fact that we are not necessarily giving the same high dose as we've given in the first course. So that's why we anticipate already inferior local control. And maybe there's still some form of reduced radiosensitivity if we were not successful in the first place. So there is already some indication that radiation will not effectively irradiate over time. But still, currently, there's no clear indication that after first course of radiotherapy, a second course is really less effective. It's rather a question whether we are able to give the right dose. Now, if we look at the toxicity, and unfortunately there, a lot of the data is accrued incidence. That's one thing. And on the other hand, it's not sometimes well differentiated whether this is by imaging only or also symptomatic. Only where I indicated like grade 2, 3 or symptomatic radiation necrosis like here. Now my pointer disappeared. Like here, we really can say that the rate of radiological radiation necrosis is significantly higher than the one that is then seen as a symptomatic radiation necrosis. And if we look in the literature for the de novo primary radiosurgery, the symptomatic radiation necrosis is also in the range of 5%. And here we are between 7 to 15%, which looks quite reasonable. Of course, due to patient selection, overall survival is quite different, but it looks reasonable. And it's at least not significantly shorter than 1 year. And for me, that's a reasonable target time we should envision that we should treat and retreat patients that really have an overall survival expectancy that is at least 1 year if we have a semi-curative approach, or of course, short interval if we look at a symptomatic relief for those patients. So in general, it looks appealing from the data, but we need to acknowledge that we have limited published evidence to really guide us. And I would like to take the time to just quickly single out some of the factors that might be relevant for decision-making with the patient, with other disciplines in the tumor board. So first of all, it's also important the performance status, because the performance status is prognostic. Then it's also important to judge the extracranial disease status, because it's nice to have intracranial control, but if you do not have an effective extracranial treatment option, then local control in the brain is somewhat of a limited perspective. Then we need to consider the size of the recurrent metastasis mostly due to toxicity concerns and the selection of the dose and the time interval, because we can in the brain, in contrast to other organs in the brain, we can assume considerable recovery, so that some of the dose that has previously been given is just forgotten by the tissue. And the longer the interval, the better. And that's what you saw in the publications. The median time interval was roughly 12 months. Then when we do the treatment plan, we look at possible dose bridges. And you saw that in the previous talk when you had the round-shaped dose distributions, but then this spillage if lesions were close by. So we look at those dose bridges and really try to judge what is the dose received by the normal tissue. We can consider fractionation. So the more we portion a treatment and the lower the single fraction, the better tolerated it is. And of course, we can judge by the cumulative dose we are applying and then judging whether or not it's safe or not. And this can then be done if we look at the volume that receives a threshold dose of a biologically effective dose of 100 gray or more. And most importantly, it's nice to have this tool available, but these things need to be considered also with the risk associated with re-irradiation and also with the risk of not doing re-irradiation and letting the tumor grow, but also in the context of whether or not there are treatment alternatives available. So in such situations, we of course first need to discuss whether or not we can get this lesion that's probably recurring resected. And on the other hand, depending on the number of metastases, we also need to consider whether or not systemic treatment or switch of systemic treatment might be an option to control also intracranial disease. Now, if we look at those factors that really affect the re-irradiation treatment plan, we come up with so-called dose volume parameters. So these are volumes of normal tissue, the brain tissue, that receive a certain dose. And some authors have looked at it and have derived some guidance we can use in the clinics when we look at our treatment plans, and then look at different dose volume parameters to see whether or not the patient has an increased risk of radiation necrosis. And increased means an excessively high risk, like beyond the 10 or 20%, because we need to consider, or we need to assume that re-irradiation is always associated with a slightly higher risk than in the de novo setting. Then we need to judge on the volume, how large is a lesion, and whether or not we switch from a single fraction treatment to a fractionated approach to exploit the radiobiology feature of fractionation and better efficacy on the primary tumor and better sparing of the normal tissue. And one important study that just was recently published by a Canadian group looked at post-operative re-irradiation. And normally we had the dogma that we only re-irradiate if what we truly see. So in a prophylactic situation, so a lesion had been removed and then go for re-irradiation, we were rather cautious. This is slightly turning, so we're slightly turning the page there, because what we see is, firstly, even after this resection, the patient will recur and they will have a high local recurrence rate. That's one thing. And if you look at this analysis, so here are patients being re-irradiated in the time interval, and here on the y-axis you see the risk of radiation necrosis. Of course, again, you see the longer the interval, the higher the risk of radiation necrosis gets. But if you look at the black curve, you see these are the patients that have received post-resection re-irradiation, and they have a lower incidence of radiation necrosis compared to patients that have received re-irradiation to an intact metastasis. And well, we can speculate a lot, and it depends always on how a metastasis is resected, but maybe some of the normal brain that has previously received dose has been removed together with the recurrence, and if you then re-irradiate, maybe it's better tolerated. That's one point. And another thing is, most of those post-resection re-irradiations were fractionated. So maybe it really makes sense in the re-irradiation setting to fractionate to reduce the risk of toxicity. Importantly, all those studies were mostly basing their modeling approaches on radiologic radiation necrosis and not on symptomatic, because if you only look at symptomatic, you do not have a lot of events to model with. So this is really symptomatic and asymptomatic radiation necrosis taken together. Well, there are additional decision-making factors. If we again look at local control, and here the colleagues separated between whether or not they did re-irradiation around 1 year after the previous treatment. And you can also see here, if the interval was longer than roughly a year, local control was better compared to patients who recurred earlier. So maybe there's still some indications that early recurrence really confers a more resistant phenotype, maybe also the reluctance to give the higher dose. So the longer the interval, also the better the chance that the patient responds. And also, depending on the volume of re-irradiation here in this context, roughly 10 cc, you see in the post-op setting, even with larger cavities, the radiation necrosis risk was really significantly higher compared to smaller lesions. And here, with intact brain metastasis, another group found like a differentiating factor was 1 cc in brain metastasis. But still, you see the difficulties. There's wide variety, because between 10 cc and 1 cc, that's quite a range, but you see the difficulty to really model what we can say. The smaller the volume, the better the tolerance to re-irradiation. But more importantly, the longer the patient survives after that, local control matters, and we had the discussion in the morning. So the longer the patient survives, it's really important, even in a re-irradiation setting, to give the respective dose to really confer a long-term local control. And maybe it's even the optimal approach, if it's feasible, to operate on those patients and then give re-irradiation. Now, to finish this case, so the patient was then referred to re-irradiation. We opted for a fractionated approach that had also the reason that in the beginning there was a cystic lesion, and one of the assumptions was that with a single fraction, a hypoxic cystic lesion is not well controlled. That's why I opted for a fractionated approach. If we look at the 1 cc factor, well, we are just at the limit of whether or not to develop radiation necrosis, but that's actually quite favorable. Those volume parameters were also very favorable, but still, then in the follow-up, the patient developed this concentric enlargement, again with this blurry border, which is already quite suspicious of a radiation necrosis. And in the long run, and I just have seen the patient last year, I did not add this image, the patient is still with no evidence of intracranial and extracranial disease, but developed this radiation necrosis. This was asymptomatic, and it just resolved, and now we see this scar here. Well, with the last couple of slides, I would turn the attention to the repeat CNS irradiation, which can turn into a type 2 re-irradiation. And I don't want to spend too much time here, but with this repeat, we heard we can treat a lot of metastases, and we have several options depending on whether or not there's a driver mutation or not. 1 to 4 brain metastases, 5 to 10 or more than 10 brain metastases, and the options are all the same. Repeat radiosurgery, salvage whole brain, no radiotherapy at all, and switch of systemic therapy. Well, if you look into the literature, we can see, and I really wanted to point to this most important study. It's a prospective registry. We have seen the initial data, but Yamamoto also published from that registry more than 800 patients with at least 2 courses of radiosurgery. And you see that the median overall survival from the second radiosurgery is also very favorable. But most importantly, more than 80% of those patients did not need whole brain radiotherapy. And I think if we really vigorously implement this, and our data is from 2018, currently we're certainly also as low as the Zurich group with less than 10% of whole brain radiotherapy. Therapies. There's one possibility to select for patients. This is the brain metastasis velocity, because we still need to see whether patient benefits or not. So this is just the number of new brain metastases developed since the initial radiosurgery divided by the time. We can build a score, and then we can judge on the prognosis of those patients. And if the prognosis is longer than 1 year, I think it's reasonable to do re-irradiation and repeat irradiation. We have validated this score in our own patient cohort. We've transferred this to oligometastatic disease. I think it's a simple metric. It would be nice to prospectively evaluate that. To sum up, for the repeat CNS irradiation, I think for 1 to 10 brain metastases, we can transfer the analogy from the de novo radiosurgery space for more than 10 brain metastases. This is really individual decision-making. We do not have evidence, and there we need a thorough discussion in the multidisciplinary tumor board. So in general, I think in-field re-irradiation is feasible. It's effective. We have limited published evidence. We need to change this. Repeat radiosurgery is certainly viable, and we need a proper patient selection. And to really aid with the prospective validation, it's really difficult, but I'm very happy and glad to see that we have this EORTC Astro E2 Radiate prospective registry, and also with the cohort for re-irradiation open. We will hopefully hit in May the 500 patient, and then open for new sites, and intend to include 2,000 patients. And with this, I hope to address more of the open questions I've alluded in my talk. Thank you very much.
Thank you very much, Nicky. Questions? Maybe I could start it. How's the time interval between radiosurgery, local recurrence, and re-irradiation influencing the risk of an later radionecrosis? So you might assume that patients are living longer now. So what we indeed see is late local recurrence. I just last week had a patient in my clinic. We did treatment in 2019, radiosurgery, breast cancer patient. She's perfectly fine. She was on an HER2-directed therapy, and now she had a local recurrence. And is a re-irradiation in that setting safer? Because there might be some repair after the first course. Is it the same? Is there any data?
Well, there's not, also where there's really good data is in a rhesus monkey re-irradiation for spinal cord. And there, the interpretation is that after 2 years, almost everything that has been given in the initial course.
But that is conventional fractionation in spinal cord.
And that's the problem. It's difficult to translate this into a brain and radiosurgery approach. And one thing we need to consider, most time intervals stop at 2 years. So my personal perception is, even if we wait long enough, like 5 or 10 years, there we might see subclinical damage we induced by irradiation, which is not apparent in the first 2 years, might get apparent 5 or 10 years later. So we can suspect that even the longer the interval, like 5 years later, there might be a higher risk in certain situations with re-irradiation. With the brain, we have the indication of recovery, but it's difficult to answer. And there's another effect with your particular patient. Sometimes recurrences after re-irradiation develop over a very long time span. So it's not a rushing progression. Sometimes it's really over time, especially if they are cystic and are slow-growing recurrences. But whether it's safer, difficult to say.
Thanks for this very nice presentation. So one question, when cases where you do another re-irradiation of a previously irradiated lesion, and you do not really, is it recurrence or is it some unspecific change, quotation mark, necrosis? What's the role of PET imaging for you for the decision-making whether to embark on immediate re-irradiation or wait and scan?
I think what's important is the patient symptomatic or not, and what's the intracranial, extracranial disease status, and does it have a consequence if we do the image, and will we then also treat? In many cases with these equivocal results, and the patient is asymptomatic, we resolve to a follow-up scan, because we also need to have a respective size so that the FET PET can pick up the signal. But we mostly rely on the FET PET, and I mostly rely on Martin. And sometimes I personally call him to really get an answer. Do you consider this a recurrence or not? And that's a relation of the background, the activity background, but in the end, it's individual judgment, and we need to make the decision in a multidisciplinary fashion. And yes, there are certainly cases we may re-irradiate which are not true recurrences.
Maybe a short question before I hand over to you as a surgeon. So if you resect or kind of do an operation on radionecrosis, do you see differences in the brain if you do that after a year, 3 years, 5 years, 10 years? So is there long-term changes after radiosurgery, which you recognize makes it more easy or difficult to do the surgery?
Basically not more difficult. What we see is something which we would assume to be like gliotic scar around the lesion. And this sometimes helps us to dissect. But in any case, especially when it's in a non-eloquent area, we would also resect this so-called scary or gliotic tissue, which may end up in a supramaximal resection, but it doesn't make it more complicated.
Okay, thank you. Luis. Squeezing through.
No, Just to quickly add something about the recognition of radionecrosis. Actually, in our data, because actually we measured the volume of the lesions and correlated that with the very final outcome of each one of the lesions. And the only outcome that becomes significantly different from the others is necrosis. So normally when you have necrosis, your volume is much more bigger than any other outcome. So normally a lesion that evolves to a radionecrosis will grow faster than tumoral progression.
In hindsight, that you can only see this in retrospect how fast it grew.
Yeah.
My question was when you have the suspect of being either a recurrent situation which you might to treat early on, or a necrosis where you just wait and scan whether the PET imaging helps. So we felt that this was in our tumor board always the game changer.
Okay, if there's no further question, many thanks, Niki, and it's a pleasure to hand over to the next speaker, Dr. Florian Putz. He's from the University Clinic in Erlangen, and he has a strong track record in kind of asking a question what automation, artificial intelligence can support us in treatment planning, response assessment. So what is the value of AI in brain metastasis? Looking forward to your talk.
Yeah, thanks a lot. Okay, now it's better. Okay, so thanks again for the nice introduction. We now come to an interesting topic, AI applied to MRI for brain metastasis. So in the first part of the talk, we want to have a look at deep learning auto-segmentation for brain metastasis, which can help with radiotherapy treatment planning and also with having a better quantification of the disease-extended brain metastasis. Then in the second part, we want to have a look at the current state of AI-based predictions in brain metastasis. So we will have a look at radiomic approaches and also deep learning approaches. And then finally, we want to have an outlook at interesting novel deep learning technologies that could also be interesting for brain metastasis. So first, let's look at auto-segmentation for brain metastasis. So auto-segmentation means that an artificial neural network, a deep learning model, decides for every voxel, every MRI voxel in the image data set, if it belongs to a brain metastasis or not. So that's a voxel level classification. And with this voxel level classification, we can address multiple different clinical applications. The first one is to identify the brain metastasis in the MRI imaging volume. So for example, for treatment planning or also for diagnostic purposes. The second one is to find the boundary of the metastasis for treatment planning. And finally, we can also use it for volumetric assessment and for volumetric response assessment. And so what's interesting to notice that all of these auto-segmentation applications, they have become available as medical products for actual clinical use. So that's something that already is available in the hospital. So first, let's have a look at deep learning auto-detection for brain metastasis. So that's an exemplary deep learning model, a 3D convolutional neural network that takes in subvolumes from the MRI data set. They are subsequently processed and then segmented. The model outputs a segmentation mask. And this helps us with two different clinical tasks. The first one is to identify the brain metastasis. And the second one is to find also the perimeter of the metastasis, because of course for treatment planning, we need to encompass the whole tumor surface within a certain dose. So I think many of you will be familiar with auto-segmentation for gliomas. So there it has a long-standing research there. So it's quite similar in brain metastasis, but there are also some differences. So one major challenge is in brain metastasis that we here have multiple tumors, and they also have vastly different sizes in terms of volume. So we saw this
so this relationship that the volume increases with a certain potential of the diameter, and therefore we have vast differences in volume, and this means vast different numbers of voxels per metastasis. And the conventional deep learning auto-segmentation models therefore will mostly learn to segment the large metastases that are composed of multiple voxels, and they usually tend to miss the smaller metastases. So therefore, for dedicated auto-segmentation models for brain metastasis, they usually have some modifications, especially to the training part of the model, so that the model also learns to segment to detect the small metastases. So, and with these dedicated deep learning models like dedicated convolutional networks, a high detection accuracy is possible and also good contouring accuracy. And what is particularly important, of course, what we care about for these AI applications, we also have good generalizability, that a model can also be applied to data from other centers. And that's also something we looked at in a recent publication, a multi-center publication, also in collaboration with University Hospital Zurich and University Hospital Erlangen. And there we also found quite a good generalizability, which could be further improved with strategies for multi-center training. But to give like a ballpark number for the performance of these models at the moment, also like the models that are available right now as medical products from the medtech industry, then usually we have a detection sensitivity of above 90% with a false positive rate of less than 1 per MRI study. So that's like the state-of-the-art performance. Of course, depends on the exact data set, but that's what usually can be expected. So, but of course, what the question is here is especially what is the clinical benefit of using these deep learning auto-segmentation models for brain metastasis. And now there have been numerous studies that looked at that, and also from multiple different lenses. This is an interesting study from neuro-oncology that looked at the clinical benefit from the perspective of the radiation oncologist. And here they found that using these deep learning auto-segmentation models as assistant systems, the detection rate of the metastasis could be improved. So when they compared the physician, a radiation oncologist with the AI assistants compared to the radiation oncologist alone, the detection sensitivity was significantly improved, 90% of metastasis instead of around 80%. Then also the target volumes were improved, and in particular there was improved standardization. So we can also see this on the lower right of the screen. So with the AI assisted workflow, the target volumes became much more similar. And then finally there was also a time-saving benefit, which of course is also important for our resource-constrained healthcare systems. But I think the most important factor is the higher detection sensitivity, and this was confirmed in numerous studies, so that we really can improve our target volumes with the help of AI auto-segmentation. This is another study that looked at it more from the perspective of the diagnostic radiologist, and they also found impressive figures. Multi-center study, they found a detection sensitivity, that the detection sensitivity increased from 70 to 80% to above 90% when using such deep learning systems as assistance systems for the clinicians. So there's also a word of caution. These technologies, they do not replace human experts. In fact, human expertise is still required in the same manner. And less experienced clinicians, they tended to produce more false positives when they use these deep learning algorithms. So clinical expertise is essential in finally judging the predictions made by the model. So one interesting question is, I think, how can these models help us human experts? How can they perhaps have some physiological advantages compared to us clinicians? And I think one interesting aspect is that they have kind of these 3D models. They have something like what you could call a real 3D vision capability. So they can assess a 3D imaging volume at once. They can learn 3-dimensional features, whereas of course we human beings, we are still limited to looking at a sequence of 2D sections. And this may help with the detection of small metastases and to differentiate them from small vessels that both appear as circular cross sections, but have, of course, completely different three-dimensional shape. But what we stressed before is that, of course, human oversight is still essential. And in fact, I think these deep learning tools, they are just tools like other tools we introduced in medicine before. And it's are really tools that need to be used by human experts in an interactive fashion. An example for such an interactive workflow that was created for scientific purposes is shown here. So first, we have a deep learning model how to detect the brain metastasis. Then we have human experts judge if it's a brain metastasis or not, so accept or decline the individual predictions made by the model. Then in a subsequent step, a human expert may need to mark metastases that might have been missed by the algorithm, so that they also can be subsequently automatically segmented. And finally, the last step, the correctly identified brain metastasis did also be correctly contoured, and there's a subsequent correction step of the contours of the correct perimeter of the metastasis. So what is interesting and what we also heard about before from the colleagues from Lausanne is that auto-segmentation also helps us with accurately quantifying the size of lesions and on an individual voxel level. So, and this, I think, has caused renewed interest in volumetric response assessment so that we can track tumor size during follow-up with auto-segmentation. And here's one example shown on the right. So these are multiple frames from multiple studies, MRI studies in one patient after stereotactic radiosurgery, positioned together for a video. And here we can see that the deep learning algorithm in red is the segmentation successfully tracks the lesion. And we can see in the center the extracted volume, and that was quite similar to the manually segmented tumor size. So technically, this is quite easy to do. In fact, it's easier to detect the metastasis because here we already know where the metastasis is. We can train a simple 3D unit, for example, to auto-segment metastasis in the center of a subvolume and use that for tracking of the volume during follow-up. And this can even be automated for automated response assessment. So volumetric assessment may have some advantages compared to unidimensional measurements. So first, it might be superior to quantify the lesion size for larger metastases in more complex shapes. It may have a higher sensitivity for small changes in tumor size. It is invariant to differences in the slice plane. So if the MRI scan is tilted, and it also may be a better metric of lesion size, which is used for decision making. So because a metastasis that has the same diameter can have vastly different volume, of course, because of a different shape. And so we see, I think, increased interest in volumetric response assessment in brain metastasis. This is an interesting study from Oskara and Federau, and they compared volumetric measurements compared with diameter measurements in small metastases below 1 centimeter in size. And what we can see here is that for the same diameter, so within these box plots, there was a substantial distribution. So the lesions showed vastly different volume. And also for lesions with the same diameter, so between these box plots, there was a large overlap in volume. So here they concluded that a substantial difference in diameter was required to detect a difference in volume. And this means, of course, a reduced sensitivity, for example, for assessing treatment success and failure in systemic therapy and local therapy trials. So one interesting study I also found, so which we already saw before from the colleagues from Lausanne, I think also indicates the renewed interest and the potential of volumetric assessment in the follow-up of brain metastasis that is possible with deep learning auto-segmentation. So this is a recent study that was just published a few days ago, And here they made an interesting comparison. They compared normal diameter measurements for brain metastasis, volumetric assessment with automatic segmentation, and volumetric assessment with manual segmentation. And so what they found is, so what also could be expected, is that there was an improved stability with this automatic segmentation compared to the manual segmentation. Also an improved inter-observer variability. But I think what was most important is that the actual outcome of the metastasis after 1 year was best predicted when using the AI auto-segmentation together with the volumetric assessment. So I think we can say that there is increased interest in this volumetric analysis for brain metastasis. Certainly, this is something that has become feasible with AI auto-segmentation. So one of the advantages of using AI auto-segmentation in brain metastasis. But of course, when we track the size of tumors, for example, after stereotactic radiotherapy, when we have a growing lesion, so what we would like to tell if it's what we also discussed before, if it's really progression or if it's radiation necrosis. And there, of course, the interest is, could AI help us here in regard to predictive tasks? Yeah, and I think the potential is quite large for AI for predictive tasks in brain metastasis. In fact, you may argue that we have just seen the tip of the icebergs with these auto-segmentation tasks that may seem perhaps a little bit less encouraging, but they have already reached the clinical stage. But there are numerous additional tasks that could be possible with using AI in brain metastasis, for example, differentiating local progression from radiation necrosis, or also for perhaps improved survival prediction, integrating the imaging data. So what is the current state here? So a lot of work has been done with radiomics. I think all of you are familiar with radiomics. So the concept is here that we have a predefined segmentation and we have predefined features. And then we extract hundreds of these features that are defined by predefined formulas. And then we perform a feature selection step and subsequently model fitting. So there has been some success with using radiomics in brain metastasis. One recent study was published last year in Neuro-Oncology. And they used radiomics to predict local failure in brain metastasis treated with resection and with radiotherapy. And so I think this was very good study design. They had 5 different external test sets, or they have an external test set composed of multi-center data from 5 centers. And they found that the combination of radiomics with clinical factors was superior to the clinical factors alone for prognostic prediction. So what is also interesting here is that, on a side note, that a volume of the tumor alone was also quite prognostic. So the concordance index here was also around 0.76. But nevertheless, I think the results are quite impressive, especially when looking at the stratification capabilities to predict local failure risk after 2 years. But there was also were also more sobering results for radiomics within brain metastasis and also outside of brain metastasis, so that there perhaps are some methodological problems, also limitations with using radiomics for predictions. One example in brain metastasis was also published last year in Neuro-Oncology Advances, and they tried to reproduce to recreate a model to predict the primary tumor histology from the imaging data alone using radiomics. And the model did work quite well in the internal data set, in the internal validation, but when using external data sets, the performance dropped considerably, and it was only in the region of random chance. So they failed with fitting a radiomics model, and they also found different statistical problems that may lead to over-optimistic assessment of these models that mostly are discovered with using external test sets. Nevertheless, I think there are also some sobering results in regard to radiomics. And one reason may be the high variability in the data, and especially these radiomics features that are quite, you could call it shallow features, so that have a low level of abstraction. They might be more susceptible to heterogeneity in the imaging data, like changes in the imaging noise that we frequently see with MR, different sequences and so on. So the question is, like we saw with the outer segmentation before, is deep learning also the answer for prediction in brain metastasis? So here the concept is different. Instead of extracting features, and instead of using predefined features, we have a deep learning model that during the training learns the features for the prediction itself. And because we have multiple layers, the model is able to have a high level of abstraction, so can perhaps detect features that are more clinically meaningful and that are less susceptible to changes in the imaging data. So that's one example for using deep learning models for predictions in brain metastasis. They again predicted local control or local failure using a deep learning model, a 3D ResNet in this case, based on the imaging data alone. And in this study, they found quite good accuracy in terms of the AUC, but that was quite promising, but they did not have an external test set here. This was also one rather early study from the engineering fields. So I think there is not so much work on deep learning models for brain metastasis yet. So the question is, what could be interesting for the future in brain metastasis? What are interesting novel deep learning technologies for predictive tasks in brain metastasis? And to get an understanding of this, I think we need to look a little bit outside of brain metastasis, basically over the fence of brain metastasis. And so one region to look at is always gliomas that sometimes receive a little bit more attention in neuro-oncology and where newer technologies are perhaps sometimes introduced earlier. So for gliomas, recently papers were published that used multimodal transformer models for multimodal data integration. So for example, for predicting prognosis of the patient, or also for pseudoprogression classification. So for differentiating pseudoprogression from real progression. And the concept here is also quite interesting. So here, instead of just taking the imaging data as an input, the model also takes in the clinical data, which is then integrated in the deep learning model for a superior prediction. So for example, for pseudoprogression classification, the model would not just get the imaging data as an input, but also the time since the radiotherapy, the dosimetric parameters, so how the enlarging lesion is related to the initially applied dose distribution, or for example, neuropathological factors like the MGMT promoter methylation that also had been discovered to be predictive for pseudoprogression classification. And so with these models, some studies have found that they outperformed existing deep learning approaches for predictions based on multimodal data. And I would say that these multimodal deep learning models, transformer models, using cross-attention fusion are also promising for brain metastasis research as well, particularly for differentiating radiation necrosis from progression, for example. So another interesting development, deep learning technology, I want to show in the end. I also think what is promising for brain metastasis are foundation models. They were introduced in a seminal paper in Nature Machine Intelligence last year in the context of CT data. But the concept here is also quite interesting and could perhaps address some of the limitations we have with these conventional radiomics. Here we have very large models that have a lot of trainable parameters, and they are trained on vast data sets. This allows the model to have superior performance and also generalizability, so that it also works well on data outside of the training data distribution. And for imaging biomarker discovery, we can use unlabeled data sets for training and train in a so-called self-supervised manner. And that means, of course, we have much more data. We could use any brain metastasis images we have without any labels. And the model basically learns to understand the brain metastasis, or in this case, the imaging data, and to convert it into meaningful features. And these features from the foundation models then can be used in a quite similar fashion to the radiomics. They can be extracted and used together with non-imaging feature in linear models, which allows also for improved explainability. So they have shown promising results in terms of indeed superior performance and generalizability, and also working with very small training sets. So because of this pre-training on large numbers of data sets, the model then can be subsequently trained on only very few data sets, which is of course very interesting also for clinical applications. So I think these foundation features, they also hold promise as MRI biomarkers for brain metastasis, and they could address some of the limitations of conventional radiomics. They can be used in quite a similar fashion, but they are not, but they have, I think, a higher level of abstraction. They are identified by a deep learning model, and they should be less susceptible to changes in the imaging data. And this was also already in part shown in the seminal paper in Nature Measuring Intelligence. So we have to conclude. So I wanted to show today that a deep learning MRI brain metastasis auto-segmentation has already become available as medical products. So we have multiple medical products available already. And it can provide a clinical benefit, it can enhance detection and contouring of brain metastasis for treatment planning. Furthermore, AI auto-segmentation certainly makes volumetric assessment feasible. Finally, AI also holds large potential for predictive tasks in brain metastasis. We saw this iceberg, differentiating radiation necrosis from progression, survival prediction, and so on. And here, novel interesting technologies are multimodal, transformer models, and also these foundation models. So thanks a lot.
Thanks a lot for this excellent overview of what is happening in the field of AI and AI-assisted segmentation, assessment of MRI images. Questions? Yeah.
You mentioned radiation necrosis, and you also mentioned pseudoprogression. And do they appear to be different entities by AI, or a continuum, or same thing?
Yeah, so I mentioned the pseudoprogression in the context of gliomas and radiation necrosis with the brain metastasis. So I think it depends on how the model is trained. So when traditionally these models are trained in a self-supervised manner, and then some human being has decided if it's a radiation necrosis, and this is what the model will learn. But perhaps with these foundation features, we could also find some differences in the imaging data, but that's speculative, but that's of course would be interesting.
Maybe one more question. So thinking about if we have just one brain metastasis, I think the value of auto-segmentation is limited. But thinking about a patient having metastatic disease, multiple metastases, multiple brain mets, how do we kind of perform with the different trajectories of the individual metastases? I mean, just summing it all up is kind of a very crude methodology of saying this patient is responding. So could you also kind of, what is the data on looking at the patterns of response of individual metastases? There might be one progressing, there might be two, the dynamics, how they are kind of changing, that this kind of characteristics are prognostic or even predictive?
Yeah, I think it's very important, especially in the clinic. It's usually difficult with the management of these patients. We have multiple metastases. They receive systemic treatments, they receive local treatment. And so deep learning can also be used to differentiate this with the lesion tracking. But so I have to say, so in terms of the prognostic, prognostic meaning, I have not seen a lot of results yet, but it would, of course, you would think that systemic changes in the metastasis, changes in the number of metastases, systemic changes in the progression patterns, they more relate to a problem with systemic treatment, for example, whereas, of course, local isolated progression, you would think that this was a problem with a isolated progression resulting from local failure.
Because that would be very helpful in a multidisciplinary environment. Thinking of a patient, currently a report says, patient is having progressive disease, and that's a signal for a medical oncologist saying, well, let's just change the next line of systemic therapy. Yeah. If it would be a clear indication, well, the patient is stable in 90% of the metastasis, there's just 1 or 2 spots which are progressing due to heterogeneity, so that might help in that situation.
Yeah, yes, I really think that these techniques, they would allow for much more accurate assessment, so that we get a clearer understanding what is happening with the patient. Also, subtle changes in growth, local changes in local growth, and this could allow for better decision making. Because this is the same for us also in Erlangen, that we get in the report a progressive disease, and then we look at it, and then some metastases, they already were present before. They perhaps have just a little higher enhancement now. They are in fact not new, perhaps are diagnosed as new ones. So I think it's of course complicated with increasing number of lesions, increasing treatment, systemic treatment, and numbers of local treatment courses, but that's impossible. Then you would use like these AI auto-segmentation models with some conventional imaging analysis processing. Yeah.
Okay, if there's no further question, many thanks for coming. Thanks for this excellent presentation.
Yeah, thanks a lot. Thanks.
And I'm very happy to hand over to Professor Hüllner. Martin, we have been talking about PET imaging before, so every time I have a nuclear medicine question, I call you, and it's not only me, you receive many calls. How could we kind of differentiate between necrosis, progressive disease, and you will also discuss theranostics, so also the possibility or the opportunities for treatment. Thanks, Martin.
Thank you very much, Matthias. Thank you for your kind introduction, for the invitation. Ladies and gentlemen, my talk today is about theranostics in CNS metastases, mainly, of course, brain metastases. But before I start, I would like to mention the issue here. So, is it theranostics or theragnostics? Why should we be concerned about the letter G? So, theragnostics is a portmanteau of 2 Greek words, of the word therapia for therapy and diagnosi for diagnosis. The Greek language is spoken for many, many centuries. It's a language of famous medicinal persons like Galen and Hippocrates. So is it now theragnostics or theranostics? So in both words, the word therapy is actually abbreviated to thera. And this could be confused with thera, which is ancient Greek and means hunting and does not fit well here in this context. Then in the theragnostics, we have the word gnostics. This comes from gnosi, means knowledge. So this fits very well, actually. Whereas there's no knowledge, apparently, in the term theranostics, because the G is missing. However, in theranostics, there's the word theranos, and if you speak it fast, it could be confused with thanatos. This means death, which does also not fit very well here. And Theranos was also the name of a fraudulent blood test company, as you might know, and probably you've heard it in the news. Elizabeth Holmes was sentenced to a prison stay of 11 years. So the better word is actually theragnostics. This is also what famous Greek professors, famous linguists will tell you. However, theranostics is more smooth. So what we're using today mainly is the word theranostics. So what's the principle and the history of theragnostics? It's not reserved for nuclear medicine or for radiological imaging. However, I'm going to talk only about nuclear medicine, imaging, and therapy today. The principle is a combination of diagnosis and therapy. We have one compound that identifies the target that is used for diagnosis. And then we have a second compound that treats the same target, so a compound for therapy. And one example, or the most famous example in radiological imaging, is the combination of radionuclide imaging and internal radioligand therapy, RLT. And theragnostics is part of the spectrum of personalized medicine or precision medicine. If those 2 compounds are identical, it's perfect. Most of the time, this is not the case. But the more similar, the better it is. This is an overview of the theranostic principle. And basically, you have a
cancer targeting molecule. This can be the same cancer targeting molecule used for diagnostics and for therapy, or it can be a similar one. Then you have a linker that connects this molecule to a radioactive isotope. The radioactive isotope used for diagnostics, also called diagnostic radioligand, is typically nowadays a positron emitter, which is very, very short-lived, and then emits 2 photons, 2 gamma quants. So this is the principle of PET imaging. So we're using mainly PET imaging for cancer diagnosis. Whereas on the other side, for cancer therapy, as I said, the same cancer targeting molecule can be used here, but with a different radioligand, with a therapeutic radioligand, which has different purposes. It has a different emission of particles. This has a different half-life. And those are typically today beta minus, so electrons, or in some instances already alpha particles. So for imaging, we're using mainly short-lived isotopes, short-lived radionuclides with a half-life of 1 hour to 2 hours. So positron emitters that emit then finally gamma emitters. Whereas for therapy, we're using beta minus, which have a long half-life, typically up to several days. And they have a very short tissue penetration of only a couple of millimeters in tissue, whereas those used for imaging, they have a very good tissue penetration. So this is what enables you to do the imaging, whereas with these therapeutic radioligands, most of the time you cannot do proper imaging because it does not penetrate the tissues and you have no signal on your camera. This difference also explains what is the dose limiting factor. It is not the dose that is delivered to neighboring tissue or neighboring organs like in external radiotherapy. It's systemic effects. Systemic effects that arise in normal tissues, like in the kidneys for dotatate, for example, or in the salivary glands for PSMA. There's another slide which shows you the radioligands we are using. The most commonly used one are the beta particles, so electrons, and they have a small tissue range, which is quite large still compared to alpha particles or Auger electrons, and they have a rather low linear energy transfer. The alpha particles, they have a very short range in tissue and a quite high linear energy transfer. And then this is a principle that will be more relevant in the future. The Auger electrons, they have a very, very short range in tissue, but a very high linear energy transfer. I would like to spend some words on the history of theranostics. More than 20 years ago, this term was used for the first time by John Funkhauser, who was a consultant for a company called Cardiovascular Diagnostics at that time. But the principle goes back to the 1940s, where Saul Hertz treated the first patient with radioactive iodine. He did not treat a patient with cancer, but a patient with Graves' disease. But subsequently, he also treated patients with thyroid cancer. The treatment took place at the Massachusetts General Hospital, and interestingly, the cyclotron that produced these radionuclides was only installed 1 year before. And still today, radioactive iodine is used as the first-line treatment of differentiated thyroid cancer after surgery. And this is a list of his patients that he treated at that time. And you can see this would not be allowed by the Ethics Commission anymore, but this was published at that time. What are we using today in clinical medicine? There are several diagnostic therapeutic pairs that are used. The probably most common one worldwide is iodine-131 still for well-differentiated thyroid cancer, used for more than 80 years. Then also very well established gallium dotatate and lutetium dotatate for well-differentiated neuroendocrine tumors, as well as for meningiomas in some cases. Then gallium PSMA or F18 PSMA together with lutetium PSMA for prostate cancer since 10 years. And then in some countries, in some centers, also FAPI plays a role. Could be gallium FAPI or fluorine FAPI for imaging, and lutetium FAPI or actinium FAPI, for example, for therapy. And this can be used in various cancers, and approximately since 3 years, this is in use in larger quantities. Iodine-131 is a beta emitter,
and a gamma emitter, so it's the identical compound. We can use it for imaging and for therapy. It represents the perfect theragnostic principle. Gallium dotatate and lutetium dotatate are beta plus or beta minus emitters, and their chemical structure is quite similar, as you can see here. So they have a similar biodistribution, and they have comparable pharmacokinetics. So dosimetry is rather easy, although the half-life is of course different. But the fact that we have similar chemical structures and a similar biodistribution makes dosimetry at least easier for us. It is a bit different with gallium PSMA, lutetium PSMA. That depends very much on which diagnostic radiotracer you're using. Here, the structure might differ. For example, if you're using PSMA 11, this is a hydrophilic compound, whereas the PSMA 617 is a lipophilic compound, as is lutetium PSMA 617. So here, dosimetry might be challenged. Some words on brain metastasis theranostics. So in general, there are limitations, many limitations. First of all, there's really a lack of high quality evidence. Only very small cohorts have been reported to date. And brain metastases are quite rare in cancers where existing RLT, where targeted RLT exists. And it's basically part of a systemic treatment. There's no specific RLT treatment for brain metastasis. Additionally, those are typically very heavily pre-selected patients, so we have a selection bias, and these patients almost all the time have exhausted all conventional therapy. However, there are many potential targets for RLT on brain metastasis. Brain metastases are well characterized from a biological point of view. There are different potential targets, like HER2 can be found in brain metastasis, FAP, PSMA, SSTR2, whereas on meningiomas, we are rather limited to the SSTR2 or SSTR receptors. And so there are many possible suitable molecular targets for specific binding of peptides or antibodies that can be used for RLT. There are also some specific limitations for these types of metastases. So brain metastases, as you know, are not just organ metastases in some organ. They have there's a blood-brain barrier. There's also a blood-tumor barrier. So you want to use small molecules. You want to use lipophilic substances. Some slides about the evidence in the current literature. SSTR2 receptors are expressed on well-differentiated nets, for example, gastroenteropancreatic nets, but also on some other solid tumors like certain breast cancer subtypes or carcinoids arising in the lung. Sang and co-workers reported on the clinical efficacy of SSTR2 radioligand therapy in 9 brain metastases in a patient that had a GEP-NET, and they used lutetium dotatate. They had a follow-up of 3 years, and they achieved a partial to complete response of these 9 brain metastases. And then Golia and co-workers, they published a case report on a patient with a pituitary metastasis from a cancer, from a net of unknown primary, and they used different traces. They used yttrium dotatate, and they used also lutetium dotatate, but the patient was also pre-treated with octreotide. The follow-up was 16 months, and the result was a partial response of this pituitary metastasis. This is from the first paper by Zhang. This is the baseline PET on the left-hand side, where you see disseminated metastasis. And then after 4 cycles of lutetium dotatate, you see a response. And then after 25 months, there's a systemic progression. And the brain metastases are shown on this slide on the MRI. 2 of these are depicted here, and 1 month after DOTA, they seem to accumulate less contrast and shrink a bit. And then 25 months later, they're very small, and this result is maintained until the end of the follow-up here. PSMA is the abbreviation for prostate-specific membrane antigen. It is expressed, as the name implies, on prostate cancer, however, also on certain subtypes of breast cancer, lung cancer, salivary gland cancer, and also HCC. If we have brain metastases from these tumors, we might mainly find the PSMA expression in the tumor-associated vessels, particularly in cancers that have a high prevalence of brain metastasis. Mike Satekce from Pretoria, he published a case report on a patient where he used actinium PSMA for treating. Of course, it was systemic treatment, not a targeted treatment for the brain metastasis. This patient had a prostate cancer, and a complete PET response of this single brain metastasis was achieved in this case report. Unfortunately, no MRI data was reported. This is the image from the publication. The first image on the left-hand side is the baseline image, where we see disseminated lung metastasis and disseminated bone or bone marrow metastasis, also lymph node metastasis, and then this lesion in the brain. Well, looking at this scan, I'm not sure if I'm really talking about a brain metastasis, or is it maybe a dural metastasis? Could well be. I can't tell from this image. However, after one cycle of actinium PSMA, the patient showed a very nice response, not only of this intracranial metastasis, but also of the other metastases in the bone and in the lungs. As you know, there's a difference between brain metastasis and true metastasis concerning the blood supply, so it might also be an issue for radioligand therapy, how radioligand therapy is distributed to these lesions. Then the fibroblast activation protein, it is expressed in many different tumor types and subtypes, for example, in the pancreatic adenocarcinoma, in cholangiocellular carcinoma, in breast cancer, for example, in HER2 negative and triple negative, HER2 positive and triple negative ones. It is expressed not only in the tumor cells, but also in the cancer-associated fibroblasts. Wolfgang Fendler, he published a series of 21 patients that had progressive metastatic sarcomas or pancreatic cancer, and those were treated with yttrium therapy, 46. And 7 of these patients had stable disease, 1 patient a partial response. There was 1 brain metastasis in this cohort. However, unfortunately, no specific outcome data on this lesion was reported. Then another paper by Yadav and co-workers, they had 19 patients with advanced breast cancer treated with lutetium DOTACA therapy, and 4 patients achieved, 4 of these 19 achieved a partial response, and there were 7 brain metastases in the cohort. However, 5 of these were pre-treated with external radiotherapy, and also here no specific outcome data is reported, unfortunately. If you're looking into the future, there are a number of clinical trials currently on their way. These are clinical trials for different entities, for lung cancer, for breast cancer, for example, for melanoma, but also for renal cell carcinoma and thyroid cancer. And there are, of course, also many basket trials for various entities, including colorectal cancer, head and neck carcinoma, also prostate cancer. So many different trials for patients where RLT of brain metastasis might play a role. RLT plays also a role in the industry, of course. This is a map that shows you that there are many different compounds on their way from preclinical through the phases. However, the only ones that are currently approved are Lutathera and Pluvicto. Those are the only 2. There are some substances already in phase 3, and many different companies are present currently in this market. Not only the big players like Novartis, Bayer, or Bristol Myers Squibb, but also smaller companies like Telix, for example, or Mariana Oncology. It's definitely an interesting field for the radiopharmacy companies. This is a paper published in Lancet Oncology by Ken Herman. It was published at the beginning of 2020. And as you can see here, the number of nuclear medicine revenue is increasing, and this is partly due to the PET environment, but the biggest increase is seen in the radiotheranostics, so in the theragnostic environment, where we have a lot of new compounds hitting the market. And this was when this paper was published, so everything before, those were actually facts and figures, and after that, those were estimates, and the estimates were actually not bad if you take a look at the last 2 years. So the estimate for 2024 was $11.7 billion, and for 23 it was $10 billion. And this is newer data from Nova Advisors, and actually the true numbers were higher
a bit higher than what was estimated by Ken Hammer and colleagues, but they were quite exact actually. And you can also see here that there's a lot of optimism concerning this field. So in summary, theranostics with brain metastasis is a challenging field. Currently, there's very limited data on radioligand therapy of brain metastasis. It mainly represents a byproduct of systemic radioligand therapy. However, it might serve as an alternative or as an addition, for example, to whole brain irradiation. There are some issues that need to be taken into account and properly addressed, for example, the blood-brain barrier and blood-tumor barrier. Data from other lesions or from extracerebral biodistribution cannot directly be transferred to brain metastasis. Intrathecal application might be a solution for that. And another big issue is dosimetry. It is often impossible with a therapeutic compound because there is no emission that you can image with your cameras. It's only possible with a diagnostic compound, which might have a different linker, which might have a different compound targeting the receptor, and which definitely has a different half-life. And so the biodistribution might be different, the half-life is definitely different. So this is what really challenges dosimetry. Thank you very much. I'm happy to answer any questions.
Thank you very much, in particular for the Greek session at the very beginning, which we all enjoyed and reminded us maybe of our time a couple of decades back, at least some of us. Are there immediate questions?
Yeah. Maybe one brief question. Thanks so much. So in the past, we both Zurich and Munich and others had done this theranostic approach in meningiomas already, which had been heavily pre-treated by multiple surgeries plus radiation. How would you estimate the risk of additional radiation? Because that's what our internal discussion all the time. External radiation prior the progression, and then in addition the radiation of the radioligand therapy. We, at least to make this remark, we didn't see any toxicity there, but how would you in general estimate that?
That's in fact a very, very good question. I discussed it yesterday with Matthias on another occasion. So I also have no evidence of any detrimental effects from the literature. I have never seen such in our small patient cohort. And I also don't think that there is much side effect because the tissue penetration of these beta emitters is very, very short. So I wouldn't expect any major side effects.
So the case which we discussed was quite interesting. In the red journal, which is a radiation oncology journal, there's a gray zone. And this gray zone described a patient having neuroendocrine tumor and having a metastatic spinal cord compression. This patient is having systemic progression disease and is planned for radiopeptide therapy. And simultaneously, there's a planning for radiation treatment of the metastatic spinal cord compression. So the question is that going to be safe? So what is the dose contribution of the radioligand therapy on the spinal cord in addition to the radiation? How is the interaction? Is there an increased risk? And effectively, there's very limited knowledge out there. So in the end, we said, well, we can describe the knowns and unknowns, but a pragmatic approach would be there's not any data on toxicity in a combined setting. But I understood that dosimetry is quite complex and there's not much data out there. So it is a concern. It is also moving our field, but
dosimetry is not only complex in some instances, it's also just impossible because you have no radiation from the therapeutic compound. You don't know, it's a black box. And in those instances where you have very similar diagnostic and therapeutic compounds, they have a different half-life. So you know what's happening in the first 2 hours, but you don't know what's happening after 3 or 4 days.
Okay, if there's no further question, Martin, many thanks again for a fascinating talk, and welcome back. Many thanks again for staying until the last session. And usually, if you want to make people stay until the very end, you keep the very best for the very end. That might be you, Peter, or that might be you, Emilie, so you can discuss about that later on. Peter, many thanks for having you here talking about methylation, which has become more and more and more important. It will find or has found its influence in the WHO classification, where you are being one of the leading people. So we're looking forward into the insights and the reports and developments. Thanks for coming and looking forward to your talk.
Thank you very much for the introduction and for the invitation and for the organization of not only this meeting, but also our visit to Zurich. Very pleasant. I'm indeed Pieter Wesseling. I was trained as a clinical pathologist and then ended up in neuropathology and became terminally differentiated because I only do neuro-oncological pathology. And this both in the Amsterdam UMC and in the Princess Maxima Center for Pediatric Oncology. The latter is the National Pediatric Oncology Center in the Netherlands. So each and every kid that is diagnosed with and treated for cancer is done so under supervision of the Princess Maxima Center. But today the focus is on adult neuro-oncology. I was asked to talk about the role of methylation profiling in patients with CNS metastases. I figured out it's not necessary to talk a lot about what CNS metastases are about. You have the more solid tumors and leptomeningeal metastatic lesions, but can proceed with methylation profiling right away after showing that there are continuously interesting and very good papers like this one, recently published on leptomeningeal metastatic disease with Emilie and Michael as co-authors, and very nice figures in that review. But as I said, let's proceed with methylation profiling right away. By the way, I was considering the possibility that Donald Trump gave Elizabeth Holmes, well, she was granted, how can you say, to be freed from prison as well. I'm not sure if that happened, but you never know these days. Elizabeth Holmes, we have to check the lists. When you look at the tools that we as pathologists had in the past, long time ago, it was especially the H&E stained histological section, and then immunohistochemistry kicked in. That was in the 80s, in the previous century, and that helped a lot with figuring out what are we actually looking at. And then later on, also immunohistochemistry for particular molecular alterations became available. But at the same time, other molecular tools were increasingly available. And a lot of research was performed on what are the molecular underpinnings of tumors in general, including CNS tumors. And because of such findings and the fact that neuro-oncologists increasingly were unhappy with the lack of precision of our pathological diagnosis, so in the course of time, 1p19q, code lesion, IDH mutation, etc., were found as underpinnings for the diffuse gliomas. And here is a slide that I show quite often of a neuro-oncologist in the Netherlands who said when a neuropathologist bases his diagnosis only on H&E stained slides or histology, and you show it to one pathologist, you get a diagnosis, to two pathologists, you get debate, and to three pathologists, the same slide creates chaos. That was exaggerated, of course, but there for sure was room for improvement. Already in 2016, the revised fourth edition of the WHO classification had quite some definitions that were not just histology-based anymore, but also based on particular molecular alterations. And soon after that, and in fact already before 2016, methylation profiling appeared as a very promising diagnostic tool. Here you see a review of the, in fact, EANO guideline on the molecular tools that are available nowadays for making the best possible diagnosis. This is about gliomas, glioneuronal tumors, and neuronal tumors, but the same tools obviously can be used for other tumors as well. And the methylome profiling approach was hailed as the Heidelberg revolution of cancer classification and had a great impact indeed on neuro-oncology and neuropathology, because it for sure helped a lot with a more refined and a more robust diagnosis, especially in the more obscure cases. Important notion in this respect is that we know about the genetic alterations that are underlying different cancers, but there are also epigenetic changes. Maybe I don't need to explain what epigenetic means, but epigenetic also has to do with methylation. Is there or isn't there a methyl group on the cytosine nucleotide on DNA? And based on the presence or absence over the chromosomes, DNA will act in one or another way. So in all our cells, we have basically the same DNA, but the epigenetic differences make the cells behave differently. And the same is true for tumor cells. So epigenetic regulation is very important for a lot of different processes. And in tumor cells, the epigenetic, the methylation status tells something about the cell of origin and what, in addition to that, has occurred or has changed epigenetically or methylation-wise in the tumor cell. Okay, goodbye. This is the paper that was published in Nature in 2018 by David Kapper as first author, but over 200 other authors being involved. Methylation fingerprinting improves brain tumor diagnosis. And well, I just told that you can, when you look at the methyl groups being present or absent in a lot of places along the chromosomes, get a kind of methylation fingerprint. And the trick that is now done using Illumina platforms is that you use this information, but not all of the data points, but a select number of data points after development of algorithms for assigning a methylome fingerprint to a lesion. And the TSNE plot, as you see on the right lower corner, is the TSNE plot of the different clusters of tumors that were published in the Nature paper. Here you see some more information on the tool. In the 2018 papers, it was still on 450K arrays, and nowadays over 900K spots are examined. CPT sites are tested. You can use it for formalin fixed material, but also fresh or snap frozen material. And this is the TSNE plot as I just showed. Good news for us as pathologists was that there was quite some concordance with the histology-based classification. And the tool not just gives an indication of the diagnosis based on the methylation fingerprint. This is just an example, young patient, lesion in the, right cerebral hemisphere. Methylation profiling performed, and it comes out as methylation class IDH mutant 1p19q co-deleted, so that must be oligodendroglioma. It not only gives that indication of the diagnosis based on the methylation fingerprint, but also allows you to make a CNV profile. And here you see indeed the 1p19q co-deletion status. And it provides you with information on the methylation status of important genes, especially MGMT, in the situation of adult-type diffuse gliomas. This is 2 years after 2018, already many more cases included in the TSNE plot, and nowadays there are over 100,000 cases in the Heidelberg database. So the system becomes more and more refined, with the danger that when you like splitting, every patient sooner or later has his or her own tumor. So the challenge is to, on the one hand, use the more refined information, and on the other hand, not to go overboard with splitting entities that in the past we used to look at as one and the same tumor type. The fifth CNS tumor classification was published in 2021. Many more tumor types now defined based on combination of histology and molecular findings. And this is what I promised Joerg to show yesterday evening. Neuer in the, subway station in Munich, right? But in Munich, they did not show the WHO volumes, no. The fact of the matter is that for quite some tumor types, methylome profile is now listed as desirable or essential diagnostic criterion. Desirable means nice to have, especially when you're in doubt if that is the right diagnosis. And essential means you really should have it, otherwise you cannot make the diagnosis. And that's true for very rare tumor types like this one, diffuse neuronal tumor with oligodendroglioma-like features and nuclear clusters, D-JONC, very, very rare. In fact, so far a provisional tumor type in the WHO. Then methylation profiling for the diagnosis of CNS metastases. Yesterday I asked Emilie, are you sure you would like me to talk about that? Because we don't do it in routine practice that much. And then Emilie told me, yes, please go ahead. We would like to learn how it can be of help for metastatic CNS tumors. So then I had to think hard about how to manage that. But I found a solution, I hope, that fits. I'll show you some illustrative cases and discuss general principles based on these two cases. First patient, 38 years young, female patient, no relevant medical history. Had a neurological problem or problems. I'm not sure what exactly it was, but imaging showed a ring-enhancing lesion, and the neuroradiologist in Amsterdam figured out this probably is a high-grade glioma or a metastatic lesion. Didn't look like an abscess. Here you see an H&E stain slide, very cellular tumor, somewhat epithelioid-looking cells, immunohistochemistry, tumor cells positive for melanocytic markers. There was a lot of proliferation going on in this tumor, so it looked like a malignant melanocytic tumor. But then you still have to make up your mind, can it be a primary or should it be metastatic? The fact that it's intraparenchymal is a quite strong argument for metastatic, but the patient was not known with a primary tumor. So we performed NGS, DNA analysis, and NRAS and TERT promoter mutations were found. And we performed methylome profiling, knowing that metastatic melanoma also is in the CNS tumor classifier of Heidelberg. Here you see the CNV profile. In this case, it doesn't tell you a lot, but sometimes the CNV profile also provides you with very relevant information. And in this case, the fingerprint was, well, an indication with a very high confidence score for melanoma metastatic. This is in fact a case example that was very recently published in this paper that you see here, pathological diagnosis of CNS tumors in adults, what's new. And one of the conclusions is in cases where the diagnosis remains uncertain, molecular testing can be particularly valuable. And that's true for methylome profiling as well. But at the same time, we have to realize that the WHO diagnosis is based on diagnostic and prognostic markers and not in the first place on predictive markers. So when you want to find leads for additional treatments, you have to go through a next round of molecular analyses quite often. Other advantage of methylome profiling, apart from the fact that you get a kind of independent suggestion for a diagnosis based on the methylome profile, another advantage is that you can use the raw data and feed it to another classifier and see what comes out of that. And this doesn't cost extra money because you can use the raw data you already have. And also the time, the turnaround time Doesn't need to be too long, but because you can do it, feed it to the classifier, and within a couple of minutes you get the result. So we fed this methylome profile to the Bethesda classifier, and here you see the result. Basically, the CNV profile is the same as you expect, but again, the class melanoma metastasis, you can't decipher it from melan per se, but that means melanoma metastasis with a very high score. So that was reassuring. And now a second patient. This is in fact a patient that was published recently in the literature in neuropathology and applied neurobiology by French colleagues. 59-year-old man having previously been diagnosed with non-metastatic bladder carcinoma, considered to be in complete remission, and presented with progressive right hemiparesis. Here you see the imaging. Pathology is also imaging, but you know what I mean. And here you see histology, including immunohistochemistry. Long story short, very cellular tumor, high-grade malignant, did not show features of high-grade glioma right away, but was also not classically metastatic carcinoma because there was no keratin expression. It did show synaptophysin and other neuroendocrine features. Then methylome profiling performed, and with a very high score, the suggestion of medulloblastoma was made. And when you go back to the imaging, this doesn't look like medulloblastoma because it's not in the posterior fossa, obviously, and medulloblastoma, by definition, should be in the posterior fossa. Can still be a metastasis of medulloblastoma, but then you expect to also see something in the posterior fossa. So that's weird. Here you see the CNV profile. And after all, based on review of the bladder tumor, in which in some areas there was also neuroendocrine differentiation, a lack of keratin positivity, and the same immunohistochemistry profile as was found in the brain metastasis, the tumor was diagnosed as brain metastasis of urothelial neuroendocrine carcinoma. The lesson to be learned: if the tumor type analyzed is not present in the reference data set of the classifier, the tumor may be clustered with the closest tumor type, and sometimes with a very high score. So that's misleading then. This means that, in fact, you have to be aware of what is covered by the different classifiers. And for the sake of this talk, I screened the most recent version of the Heidelberg CNS tumor classifier, which is version 12.8, for what is there information-wise on carcinomas and what on metastases. For some tumors, it says that, for instance, metastatic medulloblastoma can also be recognized as such, but for the carcinoma metastasis, there's no information. And there is one metastatic lesion that is included, and that happens to be melanoma metastasis in this version of the classifier. Carcinoma, there is one tumor type that is listed, and that's sinonasal undifferentiated carcinoma IDH2 mutant. And there you see lower the methylation class melanoma metastasis. But then I thought, well, let me try to figure out if and which carcinoma metastases are included in the Bethesda classifier. So I sent an email last week, and I didn't want to contact Ken Eldaki directly because I knew he was busy, and then learned that you were very busy last week too because you were in Hong Kong. But a colleague of Ken then answered me with this information. We do not have a classifier for carcinomas. Instead, our CNS classifier contains a limited number of metastatic carcinomas. And here you see them listed. So when you have the impression that it could be a metastasis, don't use the Heidelberg classifier so far, but use the Bethesda classifier could be the instruction. The Sinonasal undifferentiated carcinoma IDH2 mutant is also in this classifier, which is interesting because I'm not sure if that's a metastasis of such a tumor right away, or growth per continuitatum from the sinonasal area through the floor of the base of the skull into the brain. Let's get back to the first patient again. Ring-enhancing lesion, as I already showed to you, was analyzed also by the Bethesda classifier. And you get for free, you have to pay for the test and et cetera, but as soon as you have the data, you can, in a way, play with it. You get also a UMAP representation of where the tumor fits. And here you see the tumor of this particular patient indicated in the metastatic melanoma cluster. But when you take a closer look at that area, you see that there is indeed breast carcinoma, colorectal adenocarcinoma, lung adenocarcinoma, etc. So that is another way of looking at the information that's obtained by methylome profiling. Where does it fit in the UMAP? It's not the ultimate truth, but it's reassuring when both the indication based on the methylome fingerprint and the UMAP representation, which are, by the way, of course, very closely related, fit in the same basket. There are do's and don'ts with regard to how to use methylome profiling. And very recently, a paper was published in Neuro-Oncology Advances with recommendations on this topic. Maybe I should explain what C-Impact Now is about, because this is a consortium established already in 2016, right after publication of the revised 4th edition of the WHO classification. It was started by Andreas van Duimeling and David Lewis, and also has a clinical advisory panel, but most of the other members of this consortium are neuropathologists. And the idea is that this consortium facilitates input and consensus review of novel relevant data, provide possible guidelines for practicing diagnosticians, and provide guideposts for future WHO classification. Between the revised 4th and the 5th edition, 7 updates were published. And after the 5th edition was published, it restarted its activities. 4 working groups were assembled, one of them being about methylation profiling as a diagnostic tool. And that's the working group that very recently published this paper. There are some recommendations that are very crucial in this respect. I highlighted them in yellow here. Awareness of both attributes and limitations of methylation profiling as a diagnostic tool is important. Results should always be interpreted in the context of all appropriate information. And, but maybe this is a little bit biased because there are quite some neuropathologists involved in this endeavor. A review of results by a neuropathologist is recommended as good clinical practice. And also some other recommendations or information provided, for instance, a specific case which does not fit in the existing classifiers may be pinpointed later on in new versions of a classifier, because then other tumor types are sufficiently represented in that new version of the classifier. So methylation profiling analysis is a very powerful tool, but it also has its shortcomings. It's relatively expensive, time-consuming, and importantly, for tumors for which therapeutic approaches are considered, ultimate proof must be provided by orthogonal methodology with regard to is the particular genetic alteration or molecular alteration present or not. Because based on the methylome profiling, for many of those alterations, you get an indirect reflection rather than the exact information on presence or absence. There are increasingly new ideas on how to deal with CNS metastatic lesions, I should say, metastases in and around the CNS. Here's another very recent review. And as you can imagine, for many of the therapeutic leads, predictive markers, you use as a pathologist other tools than the methylome profiling analysis. This could be perceived as time-consuming and expensive, but before you know it, we're penny wise and pound foolish, because the best possible diagnosis and the exact information on presence or absence of particular predictive markers can also save money, apart from the fact that it can do a lot of good to the patients. And then I figured out that I should not talk about nanopore sequencing that much anymore, because last year I also was invited to give a talk, and I already shared some information on that approach. But nanopore sequencing, very briefly, is a new kid on the block, and it has several advantages. One being that you can obtain real-time information on the DNA composition, including presence or absence of methyl groups on the C nucleotides. Here you see a paper that was published in Nature in 2023, describing how you can use it even during surgery. So when you organize it in an optimal way, you can get a result within 40 minutes after starting the analysis. And this, for neurosurgeons, sometimes is enough to change their therapeutic or intraoperative surgical strategy. So nanopore sequencing, based on deep learning methods, can allow us to pinpoint the diagnosis with a high confidence score within a very, very short time, even within 40 minutes after starting the procedure. But to use this deep learning method, you have to have information on, let's say, methylome profiling based analyses as were performed by Illumina platforms. So it doesn't work yet for tumors that are not well represented in the classifiers I just mentioned. And this is another example where nanopore sequencing did a very good job, because it allowed CSF diagnosis of what appeared to be primarily leptomeningeal growing GBM RDH wild type. The cherry is there because last year I did some cherry picking, and this was one of the cherries I then mentioned, but wasn't published yet. Classification of brain tumors by nanopore sequencing of cell-free DNA from CSF is presented here as a promising approach for initial brain tumor diagnostics and important tool for disease monitoring. But I have to say, there's a lot of promising approaches that are being presented. We still have to see what it will bring in the end. But I'm quite optimistic about what the future and even near future will look like with regard to the speed of our molecular analyses and hopefully also the costs that they will bring. Hopefully it can be less expensive and much faster. And when you don't do it, maybe be careful not to be penny wise and pound foolish. So neuro-oncological pathology is a very dynamic job. And we came from thin slicing. Thin slicing is a notion in psychology, meaning that you base your opinion on very limited information. So you see someone for the first time and then figure out, oh, I don't like him or her because whatever. Thin slicing. That's basically what we did. We made thin slices of tissue, looked through the microscope, and then said, this is this and that is that. And from thin slicing, we went to a kind of augmented reality. So we now include information from different levels and try to make a much better diagnosis for the benefit of patients. The role of methylation profiling in patients with CNS metastases, there's work to do, but I'm pretty sure we are getting there. A very useful role of this diagnostic tool as well. Predictive markers is still something that remains to be seen, but with nanopore, you can also assess predictive markers more precisely. And please consider the pathologist or neuropathologist as your partner, I mean, in professional sense, because we are willing to communicate and decide together what is adequate for the situation. Thank you very much.
Thank you very much for an exciting talk. Questions? Maybe I can start. So the DNA methylation profiling, it is now a standard of care in CNS. Where else in pathology? I just did some search. There's some work done for salivary gland tumors, where we also have a large variation, multiple tumors in the same organ. Anywhere else? I have never seen that in lung cancer, never in prostate, not even in renal, where I assumed it might play a role, but other developments extracranially.
No, it's an interesting comment and also an interesting phenomenon that neuropathology became kind of front runner in this aspect. And I think this has to do with the, well, in a way, coincidence of colleagues from Heidelberg having a bright idea and being neuropathologists. And then the data I've set at a large children's hospital there. So they had money available to sort out, is it going to work and in what way is it going to work? So they first and foremost developed it for CNS tumors, including pediatric CNS tumors, and then expanded their efforts to sarcomas and made classifiers for, more precise classifiers for meningiomas and medulloblastomas, but these are now included in the most recent version of the CNS tumor classifier. And others have worked, for instance, colleague from Munich, pathologist there, Philipp Joermeister. I'm not sure if you collaborate, but he, together with David Kapper again, did a very good job in creating classifiers for sinonasal tumors and salivary gland tumors. And I foresee that an increasing number of tumors can in the future also be classified or diagnosed using methylome profiling. But it happened to be like CNS tumors were first, and from there it expanded. That's my view. I'm not sure, Michael, you also already have quite some years in neuro-oncology, if you see it differently.
No, what I always struggle understanding is in how far this is really ground truth, right? Because we have been having the exercise of running a data set twice because we had to struggle so long with reviewer comments, and then we had significant numbers of changes, right? Depending on which classifier version we use. And you mentioned the pediatric contamination of the data set, right? The question is, when, if you would take all the 10,000 cases that we have now as the start, de novo, and would do a classifier, would it be the same? And Andreas van Dijning said he's not sure. So that means that the ground truth is a bit shaky.
No, yeah, you're completely right. And this is one of the reasons that you always should take this information as one part of the information and put it in context. And what you see through the microscope, that's one. And also a good reason to have alternative classifiers like the Bethesda classifier. And when they both come up with a very high score with that diagnosis, it means you should take it even more serious. So it's not perfect. It's never going to be perfect, but it's a very revolutionary additional level of information you get.
May I ask a question when you said ground truth? What is the ground truth in that setting? Because I understood there's only chaos.
No, the chaos part was about pathologists not being able to make up their mind. Is this an oligo or an estro or an oligo-estro, and what exactly is the grade? And this became increasingly annoying and important because the treatment started to be different. There was another interesting phenomenon. As soon as chemotherapy appeared to work for oligodendroglial tumors, pathologists were more keen on calling tumors oligodendroglioma because they didn't want to miss the opportunity for the patient that he or she wouldn't have the chemotherapy that could work. Yeah, that's how it is.
My question, I find this bladder cancer case really worrisome. So I didn't really get it. Did they also take the primary tumor and put the bladder tissue to the brain classifier? And did they also get a medulloblastoma?
Yeah, right. Yes, but it's not that surprising because the algorithm tries to fit a tumor with the best possible option in what's available in the classifier. And it's a high-grade neuroendocrine tumor. And in a way, you could imagine that medulloblastoma also is for sure it's high grade, and also is synaptophysin positive, that kind of stuff. But they indeed did test later on the neuroendocrine part of the urothelial carcinoma, and it appeared to have the same molecular alterations, including a methylome profile of medulloblastoma, but that was suggested with a lower score. And in the metastasis, it was suggested with a score, medulloblastoma per se, of above 0.9.
Yeah, and last count also question, because we are struggling with that. So Matthias, the ground truth question I think is really important, because some people jump too quickly to consider methylation ground truth, just like before we said only pathologist knows what they are seeing, and maybe at some point radiology is as good. Now the question is, what do you do if Heidelberg and Bethesda do not agree? We had several cases this year where we get divergent information. And at least I have learned now that obviously the classifiers are like people with very limited knowledge, right? Because then they can only find what they know already. Right. So how do you handle that?
Well, again, then you put it in the context of what you know from other levels of information. And when there is no clear answer with regards to does the Heidelberg classifier have it right or the Bethesda classifier, we discuss it in a multidisciplinary meeting and tell these are the options and what is wise for this particular patient. Now, fortunately, that are exceptions, but my experience, for instance, is that the Bethesda classifier quite easily designates a tumor as high-grade astrocytoma with piloid features, much more often than the Heidelberg classifier. So there is work to do to get this better aligned. But in the meantime, yeah, you have to deal with it in a clinical setting, being very cautious with not to over-enthusiastically follow the leader of one or another methylation classifier.
May I ask a question, not being neuropathologist, when you say the Heidelberg classifier, that's software, that's not hardware.
Say that again?
The Heidelberg classifier is a software, it is not the hardware. So the analysis is being done wherever, and then the results are being sent for interpretation, or is it, how does it work?
No, it's the analysis, the bench work is done in Utrecht, in my situation. And then we send the raw data to Heidelberg, and you get, when the system works, very quickly a report back showing the different levels of information. So it's matched with the information in the Heidelberg classifier, and based on that, you get a report back.
I don't see any further questions, so many thanks again. And coming to the last presentation, Emilie Le Rhun, you're talking about challenges and opportunities in Europe. So looking forward to hopefully positive news, how we can advance.
Okay, so thank you for being there and staying here because it starts to be late. So this is my disclosure slide. As we have heard today, so we have the incidence of brain metastasis quite high. Here, maybe you have already seen this slide. So we can see that, CBTR US database, and you can see that among the entire cohort, that's a population with a new diagnosis of cancer. And here you have the incidence of brain metastasis among this patient with a new diagnosis of cancer. And here, the incidence of brain metastasis in this patient with a new cancer in a metastatic and selected for being metastatic. And you see it's really quite a lot for lung, especially for melanoma. So that's quite frequent, as we know. The overall survival is also driven, at least for melanoma and breast, by the presence of brain metastasis. So that's something that really makes sense for the patient, and that changes the story for them. So the first challenges, so that would be maybe, and we have heard this already a bit this morning, the lack of standardized definitions. So here, for example, I'm sure if I ask you who sees brain mets, who's seen leptomeningeal metastasis or neither nor, I'm sure we'll get different answers from you, probably. And because we do not have really good definition of what is what. So, and yeah, if you call this, according to the UNOSMO, more leptomeningeal metastasis, because it's very close to the periphery and you have no margin between the lesion and the cortex. So this is really first a problem to agree among us what should be called what. And this is okay, strange for the slides. For the trichotel story, so maybe you have heard about these trials. This is also another interesting example. So in this trial, it was where Reinhard tumor was involved. So that's the trial on atezolizumab, vemurafenib, and cobimetinib. And so that was multicenter open-label phase 2 study. And so they published their first results, and then they got some comments from colleagues. And then that was not really clear what was about the symptomatic patient. In this trial, because it's quite practical, patients symptomatic or asymptomatic could be enrolled to try to reflect the population of patients. And so at the end, it was a bit discussion, was this symptomatic versus asymptomatic? And when they discussed, in fact, they review again the data after these critiques that they had reviewed, and they rethink of this definition of symptomatic and look also at the treatment that the patient were taken. And in fact, the results completely change. So just to show you how it's important to know what we are talking about and that we all agree. And they've republished, and so that's a nice hint, but still. And then so we discussed with Hüseyin Taubi and Reinhard tumor, and so that was a big problem for their trial. So they came to us to discuss also with neuro-oncologists what is symptomatic brain metastasis. And yeah, it was quite interesting. I must say, this brainstorming that we had together. And then we tried to come up with something that we could apply into the trial. So of course, we propose to use standardized scorecard at each assessment. And we propose how you can indicate on your scorecard or in your file pre-existing symptoms or signs, transient deficits. What do you do with these co-medications that the patient are taking and should be there considered when you assess the state of the patient? And then how to interpret these neurological deficits in patients with brain metastasis. For example, if you have stable new signs not attributable to known brain metastasis, it could be probably new brain metastasis, or it could be something else. And here you have to go through all the potential differential diagnoses to know also what you are doing. And this includes that you see you can do your MRI, but maybe you should also do a spinal MRI. So really to think and to have clear rules when you do a trial, that we all proceed the same when we are in a specific situation. So we have deficiency and changes to define brain metastasis, dural metastasis, leptomeningeal metastasis. It's also challenging to know which primary tumor should be included in a trial, because now we have a lot of different subtypes thanks to all this molecular information, and it doesn't make sense to have a trial that's not the same as, you know, for breast cancer, triple negative or HER2 positive. So, but at the end, you end up again with a lot of small entities. So that's a challenge. And also, what do you do for disease manifestation? Because you can have, should we put leptomeningeal metastasis in trial on brain metastasis only? Because the prognosis is really not the same. I don't think so, but there are people who think that should be the case. And what do you do? Yes, with this patient, really how to agree on the clear definition of symptomatic versus asymptomatic. So at least should have clear criteria in your protocol. Definition of active versus inactive. So here we also are not very happy with this. It is commonly used, but that would not be our recommendation, because in fact when you discuss this, you have an inactive brain metastasis. So what do you expect if you are treating a scar and then it's stable, but it's maybe it could be that it's even not a brain metastasis anymore. If you just see a scar, it will never change. It will stay a scar until forever. So that's important when you plan a trial to look at the prevention, prophylaxis for brain metastasis or curative trials. Also, when you look at lesion that is inactive, maybe if you do a repeat scan 10 days later, it will be a pseudo progression or a progression. So that's complicated, and the easiest is to have also newly diagnosed brain metastasis, but that we agree also on what we call brain metastasis. We also have very limited, validated, reproducible response assessment criteria. So we try to propose a scorecard for leptomeningeal metastasis and MRI assessment. And that was a big effort that took some time. The first scorecard proposed by the RANO group was just also expert opinion, consensus. And then we saw that we observe a lack of reproducibility. We had a very poor inter-observer agreement. So we came up with a new proposal, and we went through this validation process again. And now we have a tool that we can use. But for example, for the RANO brain metastasis, this has not been done yet. So again, we are using tools that we don't know how efficient they are. The reporting of adverse events also in the context of clinical trial is difficult, because especially for if you take a patient with lung cancer, it will have also signs from the disease. So you have adverse events that are signs related to the disease under study. So they are not really adverse events. That's simply signs of the disease. So do you capture them or not? You have this adverse event, also related to treatment or not. And so that's also the definition into the clinical trial. I think this we really have to be careful. So also we have highly variable inter-center management for the patient with CNS metastasis. So this is personal trauma experience for me. So that was the EVA-IO study. I'm sure Nikki, you remember this. So it was a concept. So you see here, you have that EORTC concept. So we had started to get the first approval in 2018. Then we had another submission in 2021. So you see it's a bit strange. I'm not sure you have seen a lot of EORTC study with two numbers, but and that's the design. So that was patient with newly diagnosed brain metastasis from non-small cell lung cancer. So with non-targetable drugs. So we had a randomization 1-to-1 between stereotactic radiotherapy plus treatment, plus systemic treatment versus systemic treatment alone. So that's very old concept. And the idea was to see if you need to give radiotherapy in the front line when you diagnose the brain metastasis, or whether you can use it later. Because yeah, people are doing both and are fighting each other and say they are right. Primary endpoint was local CNS PFS, because if you do local radiotherapy, you don't expect that radiotherapy on the brain will cure a liver metastasis, so that would not be fair for radiotherapy to look at the OS. And then it was quite nice. We had local central PFS, OS, response, safety. We had planned to look at cognition, quality of life, functional independence. We had a collaboration between the brain tumor group, lung cancer group, quality of life group, and the RASC. And the concept was approved also by AstraZeneca. And we had obtained, you see, a nice budget of 2.8 million. So it was, yeah, we were quite happy at the end. And I'm sorry, because I don't know what is happening to, I think it's Mac PC doesn't work together properly. So we had a first, this discussion. So we had the first endorsement by the EORTC board. So this was in 18. So endorsed on the February 18, as you can see. So for the concept. So then we had a long discussion with AstraZeneca because they wanted to wait for the result of this Poseidon trial. So it took some time. So we had this result in 2021. Then we restart the discussion, and we had to have a new number because it was a bit too long, more than 2 years. So we had to go back again from the beginning through the EORTC process. And then it was okay. So we had discussion with AstraZeneca, the budget, everything was approved. So this trial. And then we had the feedback from a new PRC, so the protocol review committee in January, and you see here rejected. So this is a bit that's what we have received. So the letter official letter in 22. So they say they don't like the title. Bon. They say that's also what Afan is written here. They say the primary endpoint of CNS specific PFS will almost certainly be superior, meaning that people who are here to do research, they know it will be superior, so we don't need a trial. So it's also a bit interesting discussion. And and then they say we will not learn about neurocognition, but it was planned that we looked at this. So we were really, really surprised by this decision. And then we have to give back the money and everything was killed. But what you can see also that PRC decisions are valid for a year. And and here it's binding. You have no possibility to appeal. So that's it. But they wish you the best success. so that's the story of EVA-IO, you can see. Which doctors are really saying the patients, that's also interesting. So that's a review. That's so we submitted a paper on brain metastasis with oncologist colleagues, and I found this. So it was from a journal with quite good impact factor, and you can see. I think that's quite really. So we review systemic therapy for melanoma brain metastasis. So here they clearly said was typically neurosurgeons who have at least rudimentary knowledge of neurology and radiation oncologists who manage this patient. Point. Nobody else is allowed to see these patients. More recently, however, medical oncologists, heavy cha-cha-cha. This is not good. No, they are not at all trained. No, they are not trained, so it's not okay. And probably the audience for this paper that we wanted seems to be medical oncologists who occasionally or also treat patients with brain metastasis. No, that's really an interesting comment from a reviewer in itself. So, okay. what can you do? So I think we have really to change our mindset for this. I liked also the talk's presentation of Luis, because that's to end on a nice, positive topic. So because you have also developed, you've also, like they have at MD Anderson, this CNS metastasis clinics, and if you have, as you have shown, I think it's very important for the patients, and it's good to see some colleagues can work together, so with different specialties, so it's feasible. So that's nice, and I think maybe we should also learn our lesson, but yeah, probably you need to have a quite volume, in fact, of patients to be able to do that, and that's a lot of time, so that's an investment. But yeah, I think that's very nice, so congratulations for your work. I think also what's problem is that there is kind of lack of interest for high-level evidence-based medicine for patients with CNS metastasis. Most of the colleagues say know what is best for the patient, so they don't need trials. Or we have trials, so this I took the trial from Rupert and Matthias, so they are friends, so I can do that. And they know, so here that's a publication in Nature Medicine, and that was also what Denis discussed a bit this morning, single arm phase 2, 15 patients. And then you go to, it's accepted in Nature Medicine, and what is the message behind? It's a bit, I think for me, if I see, okay, Nature Medicine, yeah, they say, yeah, it's good, so I will use it now trastuzumab deruxtecan, it's good. Nature Medicine, so it's fine, I do it. So you see, it's really, be careful also of all this publication, and I think we need really more strong evidence. This is a review that we did also with Rupert Bartsch, you see. We are not at war. And here we looked at leptomeningeal metastasis. So here we looked at studies published after 2005, written in English. What we can see in most of the study, so the patients are selected according to the guidelines, so that's okay, except one prospective study who did not require CSF analysis. In fact, that's even, yeah, not CSF analysis for the diagnosis. So for the workup, sorry. Most publication, yeah, did not mention if the complete LMD workup was performed, meaning clinical assessment, cerebrospinal assessment, CSF cytology. And so it was also really unclear if patients with newly diagnosed LMD or patients with progressive metastasis were enrolled. So it's really, how do you want to learn something from this? It's really chaotic, and it's not so old. We looked at also the lack of study. You can see selected prospective study for systemic treatments. We have no phase 3. Yeah, phase 2, yes, we have phase 2, but yeah, what can we learn from that? And then for intrathecal, so yes, we have one phase 1 and also a lot of, not a lot, 1, 2, 3, 4, 5 studies. So that's really a lack of evidence, and I think that's a lack of interest also of us, and we should try to improve. Another example, so we have this STRIKE trial. So that's targets immunotherapy targeted therapy with or without stereotactic radiosurgery for patients with brain metastasis for melanoma or non-small cell lung cancer. So that's a bit revival of the EVA-IO. It's still in mind, because I think it's important that we know, and we should not treat patients with systemic treatment only because there is a publication with 15 patients that has shown a bit of response. So we clearly need to know what we are doing. And what you can see, so that's very disappointing. In fact, the interest, you have first person enrolled in end of March 23. Target accrual is 190 patients, and you see the number, meaning that also here there is a bias from the colleague probably. So of course you can always blame a bit the activation of sites, but then it's mainly, I think, the way you present the trials to your patients. If you say, you should do radiotherapy, so don't do the trial because radiotherapy really is important. I don't think that's fair also for the patient, and we have to learn, and also for the next patient. So you have clearly, I think if a patient see oncologist, medical oncologist who say you don't need to see the radiotherapist, and they even don't send the patient, so there are no discussion on radiotherapy. And you have the other side when they see mainly the therapist first. So I think here it's open and we enroll, so it's good, it's peaceful. And that's also challenging because we have to involve separate units and we have to work together, and that everybody has his own rules and his way to do things. And but we have to learn to work together. Something a bit positive. So we also had this ITIO trial, so intrathecal nivolumab plus ipilimumab in newly diagnosed leptomeningeal metastasis from a patient with non-small cell lung cancer and melanoma. So this was a study that we have done here, also in other Swiss sites. And you see, we are able to enroll 19 patients. So it's in 20 months. So that was a bit what we had planned initially. So here we are quite happy that we could do it. And next, we are now trying to move to the normal step, phase 2, phase 3. But then again, it's difficult. So phase 1, that's okay, but to find funding for the next steps is still challenging. So also we've seen that with Berend a lot. So the problem of Berend is too innovative. So we have this novelty and personalized approach. So also the regulatory bodies, are they ready for this? That's the question. So we have, Berend has presented this evidence Brain Mets trial that we are trying to set up here in Switzerland. So this is what Berend has explained this morning. So we have the randomization 3-to-1. Primary objective here to look at overall survival, because here that's a systemic treatment, so it should treat everything. So we'll see. So we have an NCT number. So so everything is planned. Patient with an indication for surgery and limited therapeutic option, and they can get pharmacoscopy. So what is the story for evidence? So I joined the team here in Zurich in 2020, and I thought Berend was already collaboration with Michael, Tobias, Patrick, and the neurology. And it was interesting, but for me, I'm more a clinician. So I said, yes, that's super nice, but we have to put it to the clinic now and really to move something. And then there was this call, and Berend sent me an email, what is this? And then, okay, this is how it started. So we had the call in February 2022, first submission in May. We were invited to resubmit. You see, it's quite nice. One month later, we had the decision. So it's invited to submit step 2. So we submitted in September 2022. Preliminary positive answer 1 month later. Then we had to answer some comments again. Then we obtained a conditional approval, which is good. Conditional approval is, that means that it's accepted if you are able to move the next steps yourself. So here we started, you see, in April 23, collaboration between ETH, US, UZ, University, in fact, of Zurich. Then we started to draft the full protocol. It was finally approved also in October 23 by Anti-Cancer Fund, because you also need to get the feedback. And we could do the first submission to Basec and Swissmedic. You see, it's quite long, almost a year later, because we were waiting for this contract to be signed. That's really embarrassing, but that's the truth. So we could not submit before, we were ready. So we have submitted in December, and we got the first submission, first feedback from BASEC, and we have resubmitted. I think, yeah, you see all this regulation. We discussed also this morning with Evie and Denis. And you see the feedback from the BASEC. So for those who don't speak German, they are quite happy. They say that's innovative, that's a nice project. So I don't think they try to block it, but it's also something very new for them, and they are not really prepared for this. So Pharmacoscopy is an academically developed platform, meaning we don't have, or Berend doesn't have people to write IBs and super complicated stuff. So the result here in our trial may influence the treatment of the patient. So that's a bit complicated. So here, that's why we have to end up in these combined studies, because you have in vitro tests, plus the results of this test may influence the results for your patients. And what you can see, it was a new application and a new form. That's that's the information sheet. So how to apply, and it was completely new also from at the end of October this year. So really, it's really something they are also trying to improve. So it's okay. And another challenge, I would say, in this trial, that we have also these numerous drugs, and they are approved, but not necessarily in the indication. So that's also, we have to see if we need a label or not, no label, and how we, because we cannot also buy all these drugs. So that's a lot of discussion with Swissmedic. So now we will get their feedback soon, and I hope it will end well. And so with this, thank you for your attention, and happy to hear any comments or
Thank you very much for this overview. Some kind of food for thoughts, positive, negatives, comments, ideas, how to address the challenges. Yes.
Yeah, this was brilliant. I keep thinking of the idea of EverIO and the subsequent study, and I keep thinking whether we could get over the hurdles by doing sequencing and looking at PFS2. So SRS followed by systemic therapy, or SRS and systemic therapy from the beginning, or systemic therapy followed by SRS, and looking at the second PFS, and thus overcoming the bias of people that feel like SRS must be there, number one. And number two, looking at what we were talking about earlier, which is toxicity, and having an argument about the fact that, yes, both are necessary, both are useful, they don't have to be given together. And if you sequence, maybe you'll mitigate toxicity.
Matthias, you want to answer?
Me? I have a comment, but you were, it's your talk.
But you are
Shoot first.
Radiation oncologist, and you have a microphone.
Okay, so from a random
defend yourself.
This was the question I approached Louis before. You have a patient, 10 brain mets. You treat them all, and 1 year later, patient develops one more. You treat, and yet another year later, patient has again one brain met. That would be PFS2. It hasn't changed from the patient perspective. The patient is still having limited disease burden. He's still on the same systemic therapy. He's not symptomatic. So PFS2 doesn't solve for me the question. Relevant would be for me, is the patient becoming symptomatic? Is he developing toxicity? Or do we change the treatment strategy? For example, if my medical oncologist tells me I need to change my line of systemic therapy because I have extracranial progressive disease, or if a radiation oncologist would say, well, I can't treat locally anymore, and the neurosurgeon cannot treat either. But just waiting for a second, I think it doesn't change in my perspective. The first PFS was not really valid. The second could be the same. An asymptomatic single brain met appearing a large interval.
Avoid toxicity. If you give, say, TDXD and you wait,
and
you only radiate at progression,
I understand, but I was just saying the endpoint is not being solved by looking at PFS2. That is what I was alluding to.
No, I think for this we need the trials to look at the sequence. Yes, I think we need an answer in a randomized trial. Yes.
Any other comments?
PFS2 is the same in both arms. We have less toxicity. That is important.
Toxicity as an endpoint, yeah.
Yeah.
Any additional comments and remarks? Maybe to the interdisciplinary collaboration. I mean, what is required and most important to have a brain mets clinic and make it work?
For me?
Yeah, of course. You showed it to us. Who else?
Yeah, we're discussing with Emilie about that. Actually, just to give you an idea, when we started the Brain Metastasis Clinic, we went from 2 neuroradiologists, 2 senior neuroradiologists, to 5, and several chefs de clinique were added to the team. So, and you need slots on MRI. So there's a huge development from the radiology point of view to be able to have the capacity of follow all of these patients.
Luis, you need to encourage us. If you would make that presentation to my associate director, you would be dead at this point.
Absolutely.
I need 5 positions and more MRI slots. Wrong.
Yeah, that's the truth, and there's a big involvement from our side. So as radiation oncologists, we spend a day and a half of our week following these patients. So what do you want me to tell you? So you need more resources. So it's important to show that the whole procedures have an important advantage for the patient. We are convinced about that, and that's the reason where all these different elements were provided by the SHU to make it work. But yeah.
Please continue.
Don't want to. No, we are planning. You have to encourage us and others to develop their own clinic.
No, but you have seen the results.
Yeah, you're happy with that.
You have seen the results that we have, and we are pretty convinced that is a good way to go, to move on. That's the reason why. Well, yourself here in Zurich is the same. We are working on implementing automatic tools to help to follow up for these patients and to help to the decision of the physician when he's facing a patient that he's evolving or a new patient with different burdens of brain metastasis and so on. So I think the technological development must be performed in parallel of the clinical development to do the most cost-effective solution for the whole thing. Yeah.
Okay, thanks a lot. Do we have any final question, comment? If not, maybe a very short wrap-up. Many thanks, Emilie, for the very last and very important presentation. Many thanks to all speakers. It has been a fantastic conference. We've learned again that there's still many uncertainties, much to improve for our brain metastasis patient. We need interdisciplinary collaboration. We need to be innovative because the brain is not just, we discussed it before, a bone metastasis or a liver metastasis. We need to pay special attention to this very sensitive organ. organ. I hope that this meeting does have some contribution to further advance the field, to educate you about our clinical practice and about, well, how we collaborate and conduct research. Many thanks for coming here. Have a safe trip home. At the very end, also many thanks to you, Silke, for organizing, and many thanks yet again to all the sponsors which are making this event possible. So thanks everyone, and wishing you a safe and a good trip home.